Good afternoon. I hope that you enjoyed the morning session. This afternoon, we're going to be focusing on primary care and surgery. And we've been moving some of the program around to allow for people to speak at different sessions and go to the board meetings. So Dr. Longani has kindly agreed to move his talk up to do the surgery talk first, and then we're going to do primary care, the primary care lecture, and then primary care cases, and then we'll go to surgery cases. So Dr. Longani is one of the surgeons from Montreal, GRS, and so we're excited to have him here, or be here in your town, and to tell us more about advanced surgery, but also the approaches that they're taking at GRS Montreal. So thank you.
All right, good afternoon, everybody. Since we're in Montreal, I'm going to give this talk in French. Just kidding. All right, so there's a lot of things to cover, and we'll try to cover as much as possible. I think we have until 3, is that correct? 3 p.m., is that right? 2 p.m., 2 p.m. Sorry. It was initially done for 3, now it's 2. All right. So one of the things, the SOC just came out, so I don't know all the particularities that's in there, the final version, but I know that what was in there was that we need to have our providers in surgery that have good training and documented supervision in gender affirming procedure. What does that mean? It means that we need to make sure that there could be a fellowship training, for example. It could be a patronage with some senior partners that will take you. It will be a certain number of procedures, maybe to make sure that you achieve proficiency in some of those procedures before you are considered proficient to do that. Maintenance in active practice, which means that you do well only what you do often. So you can't just do one bottom surgery a year, every 2 years, and then have good outcomes. That just is not going to work. You need to also educate yourself, so that's one of the first disclosure. I don't know everything, and I make mistakes, and so I'm here to be educated as well, just like everybody. You're educated on surgery. I need to be educated on a whole lot of different things as well. So, gender diverse identities, expressions, terminology, all of these things that can continue to evolve as well. I try to keep up to date with everything, but sometimes it's hard, even when we're in the field every single day. And of course, so continuing education and tracking surgical outcomes, that's very important. I think it's been missing in the literature. You don't see we are seeing an increasing bulk of actually papers now talking about outcomes, but probably on smaller series and probably very skewed as well because we don't have good tracking outcome measurements. So it's starting, to pop here and there, and we still need to put our brains together to come with good tools. So we'll go over all of those things now, but you see that so in the setting of gonadectomy now, you'll need 6 months of hormone therapy. For adolescent surgery, we do it at GRS Montreal actually very often as well. But we involve a multidisciplinary approach to make sure that we're doing the right thing for the individual that fits their needs. Individually customized surgery, what do we mean by that? It means that, surgery or procedures that typically were not going all together as a bundle usually. And so it's more customized for individuals wanting specific things or specific parts of procedure that can be offered if it meets what they want to achieve, and so make sure that we meet their expectations and their goals. And then there's still only a few centers, and especially in Canada. I mean, we're a big center here in Montreal, so patients have to travel. And we need to disclose, so it's part of our duty to disclose, all the travel, all the post-operative care that's going to be needed as well after surgery. And that's very important to discuss pre-operatively to make sure that we're going to have the best possible outcome as well. And this is why we do recommend the patients to be seen for a lifelong follow-up with their surgeon. It could be a urologist if it was involving the urethra. Maybe less so for vaginoplasty procedures, but certainly for phalloplasty procedures. although it's probably a good thing for vaginoplasty as well. So it's not only plastic surgeon, it's a whole lot of different providers that you're a part of. It's a network of preoperative, I would say, preparation, and making sure that everybody's ready to get to the surgery again so we can have the best outcome. And you have so different evaluation standards. That's a little bit of a summary that we put in there. I'm going to try to move faster with that so we can get to the specifics of the actual surgeries. But what we're moving towards is more of an informed consent model of and considering things more medically necessary as it was maybe not before. What does that mean, though, is that it doesn't mean that we do consider that medically necessary, that the insurances are going to just jump on it and, for example, cover facial feminization. I know that it's not the case in Canada. Maybe move towards that in the US, and maybe we'll move towards that here, but it's not going to happen just suddenly by the release of the SOC. So. And for now, they make a big dichotomy between what is cosmetic and what is reconstructive. So, something that alters the appearance just for cosmetic purposes versus having a function. One would argue that the line is very thin between the two, and that's the point we try to make when we have to appeal the insurance denials. And some of the problems actually have to do with just how the insurance works, and that's just based on CPT codes in the US and being very gendered code, for example, and not really reflecting our reality on the field of what we're trying to do. And probably this also has to have a lot of work to be done to reflect what we're doing with new codes as well, so we can actually just have that accordingly to what we're doing. So let's start with the feminizing surgeries and a little bit of an overview of that. We'll start with facial feminization, and I'll go over different things. So you see here a pre-op picture and a post-op picture of a patient who you can notice that on the forehead, the frontal bossing is now smoother, the chin as well, the angle of the jaw a little bit less angular, and the nose is also more feminine with a curve look and what we call the suppurative break just after that tip of the nose there. A rotation of the tip as well. The nasolabial angle is reopened, so that's the distance here between the tip of your nose and the lip here. So I know I see that I apologize, but I see that some of you guys just take pictures or videos, and just for patient pictures, I will ask you not to take those pictures because they have consented to have their pictures presented in this PowerPoint, but not necessarily to be displayed everywhere. Thank you for that. So you want to prepare patients by having an evaluation to prepare them for what they want to achieve as far as what is the gender expression they're trying to achieve, what is the styling they want. Hair removal as well, very important, of course, to work on those parts of the body, just as the genital area. But so it's very important if you're doing facial feminization to have the pilosity removed, so you want to counsel the patients for that. And then you will want to wait as well to have the full effects of the hormones before you get to any framework on surgery, because the hormones will do a bunch of work for you and go to the directions that the patients are looking for. And then you'll add the frame, the structure, and then the soft tissue that you can have afterwards. So we're doing, of course, pictures. We have to talk about the expectations, and we usually do that by thirds of the face, so the upper third, mid third, and lower third, to just see what we're talking about, what we can offer for those different three areas. And CT scans, so 3D CT scans are very useful in that sense for preoperative planning. Not only to see an expected result, but also to give the surgeon tools like cutting guides, for example, that are customized and custom made actually based on one CT scan. So for a particular patient, that we will get in the operating room in a sterile envelope that we will just then use as cutting guides to make sure that to the millimeter it's going to be the exact bone cuts that we need. And that being said, this is a picture of, everybody knows them. I don't know where I was getting there. But just to show you that Typically, we will describe the more angular jaw as more, so quote unquote, masculine. But you see Angelina Jolie, and everybody probably thinks she's pretty, but she has a very angular jaw as well. So you can customize everything, and you can have different ways of looking at things. It doesn't need to be stereotyped to what we have as standards, and that's very important also to understand, because it's not up to the surgeon to say this is what we're going to do. It's up to the patient to seek attention for what they're actually trying to achieve again. So I think this is very, very important. So as far as structural surgery, that's when we're going to touch on the bone. We can cut the bone, and that's osteotomy. We can remove some of the bones. That's the ostectomy, for example, on the angles of the jaw here. You can contour the bone with burring, so it's a very fast burr that will just like contour and make things a little bit smoother. You can use implants, med-pore implants, for example, silicone implants as well on the face. You can use your own tissue to do that. You can also use fat grafting, so you do a little bit of liposuction, prepare the fat and re-inject fat in specific areas. This is actually very commonly used also in cosmetic surgery, like facelifts to enhance the face and to counter a little bit of aging. So those techniques are definitely available in facial feminization as well. And again, the 3D surgical planning, very important here. This is just an example of a frontal bossing. So you can see on the picture of the left that you have a little bit of that bossing, and then you have, it's a little bit more involving here as far as the recontouring. It's not just bird. So the anterior table of the sinus is taken out, then you can recontour the sinus and then put it back, and this is why you see plates on the right-hand side here. And the cutoff, so the decision between just burring and actually just removing a piece of bone and contouring it on the back table is the thickness of the anterior table, because you don't want to get into the sinus as you're doing that, because otherwise it has pretty bad complications. So this is what you're seeing here. From up top, this is an example of just jaw, how you get to the jaw by a gingival-buccal sulcus incision that allows you to pretty much from one end to the other end of the jaw to get access to the entire bone and to just recontour it there. Soft tissue, a little bit like I was saying. Fat grafting is definitely one of them, but there's many different adjuncts. All the techniques that are commonly described for cosmetic surgery could be used for facial feminization, of course, and this could be, but not limited to, lip lift and face lifts and brow lifts as well. You can change also the shape of the brows. It's been studied to be more angular, less angular, giving a different aspect as well. And sometimes just that can change a face and can give a quote-unquote, again, a more feminine look, or at least what the patient wants to achieve. So in this patient here, you have, again, pre-op and post-op pictures. Those pictures are from my colleague Jens at OHSU, so I don't know that particular patient. And I, again, disclosure, don't do facial feminization myself, but I'm trying to explain here what he did. So you see that their hairline is pretty far back on the pre-op here, so we went to lower a little bit the and shorten the forehead by lowering the hairline. That allows to bring this down, and then lift a little bit the brows. You have the frontal bossing again that is reduced. Sinus setback is what we just talked about, which means that you're putting the sinus a little bit back, putting it back with plates. And then rhinoplasty is pretty much always done, I would say. And one of the differences also was in the mid-face is the cheek and the mid-cheek aspect of the face being a little bit more voluminous in females in general, and so you will add some volume there to give that aspect, and then you would actually narrow the chin a little bit by doing what we call a genioplasty, which means, again, so it could be burring or it could be osteotomy, reducing and then placing it back with plates. So depending on the centers, you could be doing those surgeries either as outpatient, or you could be keeping the patients overnight and then discharge the next day. depending on what you're doing, can have like little garments to place. So for example, like chin, that's just to wrap around the head here to apply some compression, avoid having hematomas, and edema and swelling. You want to control the swelling as much as possible. This is why low sodium diet is generally used. When you're talking about the nose, now you're going to put an external splint because you're doing a lot of work both on the bone, but also on the cartilage. And the cartilage, of course, doesn't have that very strong structure, so it's just stitches. You're going to be cutting pieces of cartilage, putting grafts in there, stitching them together, and you want to cover that with a hard splint to make sure that there's not going to be any deformity for the first at least week after surgery. You want to remove the sutures pretty fast after surgery when it comes to the face, because otherwise they're going to leave track marks. So if this was non-dissolvable sutures, you want to remove them, except maybe on the hairline, which is a little bit less important if there's hair covering the incision line. Sinus precaution, so you don't want to blow your nose, for example, for a while. And then you want to limitate bruising. So arnica has been used by a bunch of surgeons as well with good effects there. We use it also very often for cosmetic rhinoplasties, even outside of facial feminization. Risks of their surgery, well, you can always get on a structure that was adjacent to where you were working, and ding a nerve that's in the region there. So all our sensory or motor nerves, for example. So sensory nerves when you're more in the upper aspect of the face here. Deeper and motor nerves, facial nerve is pretty hard to get unless you're doing what we call a deep plane facelift, where you really lift up all the different structures of the face. So you have the skin, and then the fat, and then what we call the SMAS, which is the internal soft framework of the face, if you will. And we put the tension on that layer so that there's no tension on the skin. If you remember what a facelift was before, it used to give really pulled looks on actresses in the 80s and probably 90s as well. It was really like the way to do it at the time. But anatomy has been re-understood differently, and now we're doing the pull in the layer just underneath there, so you don't have those that really pulled look. But by going deeper, you're gonna get closer to the facial nerve. So this is important. Sometimes just retractors can do nerve injury, so paresthesias, and so it will come back to normal with just some time. If you know you haven't hurt the nerve, it's just so important to counsel the patient to be patient. Complications, if this is very specific, but when we're doing sinus setback, if you don't have a proper tightening of your sinus to be placed back, you have the mucosa there that does secrete some mucus. You can have an accumulation of mucus there. That's called a mucocele. So this is something you want to identify pretty early and re-intervene, give antibiotics as needed as well, as this could be actually a pretty bad problem. Alopecia, typically it's temporary, but it's on your hairline because you're going to go around the hair follicles. There's one way to try to avoid that is when you do your cuts is to try to follow the hair follicles, so do oblique cuts and try to be parallel to the hair follicles. But still, on the hairline, you could have a little bit of alopecia where you would see the incision a little bit more for a while and usually regrows. But you need to talk about that before because it could also be permanent. Breathing problems after rhinoplasty. I can tell you I had a rhinoplasty a couple of years ago and I still don't breathe. So it does happen. Skin necrosis, depending on how you lift the skin, where you lift it. If you impact all the perfusion going to the skin, you can end up with small islands of skin that actually will have necrosis. Most times, it's really self-resolving. You do wound healing, you do wound dressings, and it does heal with time. But then otherwise, all the scar issues that you can have. And, ongoing misgendering is one of the things. Is the surgery really going to give me exactly what I want? And am I going to pass the way I want after surgery? Well, that's something to be also talked about, because maybe not. And so, the expectations are to be realistic as well. Moving down now to the neck, that's a common request we have, is the tracheal shave or laryngochondroplasty, which is the partial removal of the thyroid cartilage. It's important that everybody understands it's partial, because you can't just remove that big piece of cartilage you have in the neck that also plays a role in the voice box. And if you do try to remove it too much, you actually can deepen the pitch of the voice. So you don't want to do that, of course, because that's going to cause even more dysphoria. And so this is to be discussed. And so one of the complications is under resection, because everybody just wants to walk there very cautiously to make sure that you don't want to, have that pitch lowered. But I think that, you see the two horns here coming on the right and left side. You still can get a very good reduction of that, and the peak on the profile on the lateral aspect, you really have a peak that you can really take down and shave down to make it flatter, but it will still be there. And voice feminization surgery, to be honest, I don't know a whole lot about it, because there's ENT doing those surgeries, but there's different approach, external and internal. We have started a program at GRS with Dr. Valérie Brousseau. She has done, I think, about 10 of those surgeries so far. It's going well, but I don't know much. Yep.
For FFS, you recommended the 12 months of hormone therapy, but not necessarily required. And just curious, what are the changes that you're expecting to see? What are the risks of if you don't have that full 12 months? Just so we can.
Yeah, I think pilosity is going to be definitely something that's going to be the most, and a little bit of that skin is going to change as well, getting a little bit less oily, so it helps with the surgery. It's probably more so true even for, of course, masculinization when we get, because of testosterone effects, but I think it's mostly on the quality of the skin and the pilosity.
And let me just interject there too, in terms of some of the guideline thought process here, some of it is actually using that as a surrogate for people being engaged with care. So a situation like a breast surgery or facial feminization surgery, where it's more of a one-off, then where there's less concern. Something where vaginoplasty, where you want to know that somebody's going to come back and the outcome is going to be better if they're going to remember to do their dilations and such. There's a little bit of that. So part of it in the same space as, let's say, a bariatric surgery, you want somebody doing the diet. Okay. So the guideline gets written that way, but you have to know what's in the background of what the thinking is for the guideline. And sometimes the insurance companies or the payers, wherever you are, the provinces, if you're in Canada, might get really rigid, but we should know where we were coming from when we were thinking
Yeah.
about it.
All right, so we're moving now to breast augmentation, and the typical way to do a breast augmentation is to use an implant. You could be using other stuff, I'll talk about it. But again, you want to talk about the expectations here, past medical history, past surgical history. Of course, if there was a lot of surgeries done on the chest previously, are there any scars there? Is my perfusion to the skin going to be impacted? Is there a history of radiation on the chest that could impact what can I be using? Placing an implant underneath the skin that's been radiated, for example, is definitely not a good thing, because it will lead to more extrusion rates and also to more infections. History of breast cancer, both personally and in the family, because that could lead to prior testings as well, to make sure that before touching the breast, we have to assess for that risk. And then discussing the different types of implants. So the way I usually do that is I explain that the shell of the implant is the same, it's silicone based, and then the inside, the fill is different. So you have either silicone gels, usually now highly cohesive implants, which means that if you cut that implant in two halves and you squish on the implant, the silicone will come out, and then you relax the implant, it will come back in, which means there's no such leaks as what we used to hear before, so it doesn't go, as much in the body, if you will, versus having the saline. And so when people ask, well, what is the safest? Well, probably, if you have a rupture, then saline definitely is going to be inert, and you're just going to reabsorb that saline, and that's it. We'll just remove the shell and replace the implant. Silicone can still cause some inflammation, cause a thickening of that layer around the implant, which is called the capsule. It could lead to capsular contracture, so really, a rock-hard breast that stays very high on the chest, that could lead to pain as well. That's important to understand, and for that reason, and because we don't see ruptures with silicone implants, you have to tell patients that they need at least every 3 to 5 years to have an ultrasound. In the US, it's an MRI, so we do an MRI after 3 years after placement, and then every 2 years. MRIs could be a little bit hard to access, honestly, and so I think an ultrasound just already is a good thing. Some patients don't do it at all, but we have to recommend them to do it. Positioning of the implant, so we're going to be either above the pec muscle or below the pec muscle. And how are you going to pick that? Well, it depends on the lifestyle of your patient. So if it's somebody very active, is going to the gym and does a lot of upper body work, for example, maybe you want to be above that implant, because otherwise the implant's going to move too much and it's going to impair just a tad of the pec function to an athlete level. But for the most common people, actually, it doesn't impact your capacity to move and to lift weights if you're not performing at a very high athlete level. So I typically go underneath the muscle. Yeah.
So the ultrasound or MRI follow-up, is that just for the silicone
Yes.
type?
Yes.
And you're looking more for the...
You're looking for an intracapsular rupture of the implant so that you know that you have to change the implant. The rupture rate is 8 to 10% at 10 years, but so it means, it could vary within even the first few years after. Sometimes by doing that exam, though, you pick up on some breast lesions as well, which is, it's an add-on good thing, but yeah, that's the reason why. And then you have to talk about the volume of the implants, and you could be using different tools for that. Vectra 3D Pictures is a great tool, as it just reproduces on the patient's pictures what it would be looking like actually in real life, so they can see a little bit more. For our trans individuals going through breast augmentation, I will say that the volumes are higher than cis population, just because there's less breast tissue to start with, and so you shouldn't be afraid of seeing volumes that are 5, 6, 7, 800 cc sometimes, and when typically those are very big implants, but you have to accommodate the fact that you're starting from lesser volume. So, and in cancer surveillance, just then you have to be, involved in a surveillance that's almost beyond just the implant talk. I think everybody should when they receive hormones. This is just an example of hormone placement. You can see we don't start with much here, and this is a 650 implant placed in the inframammary fold underneath the muscle. Good thing about placing underneath the muscle in this specific type of patient here is that you see that she's fairly thin on the upper chest here, and so the pinch is very small, and so if you don't put it underneath the muscle, you're going to have really a flat and in ball sort of effect, which is not going to be natural at all. Whereas the takeoff of the breast now is going to be much more natural when the implant on the superior aspect is covered by the pec muscle. So asymmetry, you will have some level of asymmetry at first. The implants, specially placed underneath the muscle, are going to stay very high for a while, and then they will drop with time. That's because the muscle is tight at first, goes through muscle spasms. You're putting a big volume underneath the muscle that's usually tacked to the chest wall, so it has to relax with time. It will come with time, and then gravity will play as well, and then come down and nicely settle in the fold. You can have some aesthetic deformities because sometimes it doesn't stop at the fold, and the bigger the implant, the bigger it's going to push. And if you inadvertently went through the fold or the fold was not well defined, the implant's going to start its way down almost on the upper abdomen, and the nipple's going to start looking up, and the breast is going to start looking rounder and fuller at the inferior aspect, and that's called bottoming out. So you might see that as well. You have to re-intervene on those implants just to place the implant back higher, re-tag the inframammary fold where it belongs to make sure that it doesn't go any further. Loss of nipple, capsular contracture, I discussed a little bit that every single implant has some level of capsule around. That's normal. It's just the body actually reacting to the implant and just isolating the implant from the rest of the body. But that capsule can get thicker because of there's different etiologies, hypotheses at least. Infection is one of them. Leaks, silicone leaks can be one of them as well. And so the thicker it gets, the more deformed the breast can be, the more pain it could cause as well, and prompting you to re-intervene when it's too thick, in which case you want to remove all of that capsule and then change the implant. Loss of sensation, that's either you stretch too much a nerve or the nerve gets divided during the surgery. It's the lateral nerve that gives the sensation to the nipple. ALCL, you see with textured implant, that's important to know, I think. So the way there was textured implants that were teardrop shaped, like that were producing more of a natural breast look. And you can understand that because it's teardrop, if it rotate on itself, now you're upside down, you got to go back in there to place it back in the right position. So the manufacturer, to avoid that, did some texturing on the implant itself so that it doesn't rotate as much and so it sort of acts as a Velcro. We have seen over the past few years that this most likely causes a chronic inflammation, and that inflammation is at the most likely the origin of a new type of blood cell cancers. And so, in my opinion, it's not worth the risk, to keep using textured implants. There's not an official recall from the FDA, but there's like monitoring and surveillance you have to do. I don't use them at all because I think it's just not worth. But now that being said, so smooth implants don't have that problem. But just last week, actually, the American Society of Plastic Surgery just issued a new warning about squamous cell carcinoma that you can find on the capsule of breast implants, smooth and textured. So things are likely going to change even in the next few weeks. Everybody's on it right now. All right, so moving to the genital surgery. Yep. Yeah, I wouldn't look at the thickness on the ultrasound. That doesn't really matter. As long as the patient is not symptomatic and still loves the look of the breast, it doesn't really matter. If it gets really thick, they'll know it because it will be, it will be sort of like a ball on the chest and it will be painful maybe. But you're looking more at a rupture. That's what you're looking at. Moving to orchiectomy, so you could be removing the testicles or doing a scrotectomy at the same time. I realize I need to move a little bit faster because there's so much. But let's talk about vaginoplasty because this is very important. So again, important to talk about the expectations of a vaginoplasty here. Perform or not hair removal. You could be addressing the hair follicles with burning the hair follicles during the surgery. That being said, they still could be regrowing in the vaginal cavity, and this is something that the patients need to know. It could be then addressed afterwards, but it's something important to mention as well. And then also we stop the hormones. I know that Josh probably doesn't agree with that now because the bulk of literature in endocrinology says that it's actually not needed to stop the hormones, but the surgeons don't agree, and there's still fear to have one case of pulmonary embolism, and so they still stop the hormones because we're putting patients in stirrups and they stay in bed, for the first 24 hours. And
yeah, so Alex, actually you can help us because we had this conversation this morning because an alternative interpretation of the data that are used to explain why you might even hold estrogens is from cisgender young women who are stopping and starting birth control pills.
Yeah.
And in the hematology world and in the GYN world, we learned from a GYN who's sitting here that they actually think the stopping and starting is the prothrombogenic thing. So if you're going to be conservative, you ought to actually maintain the estrogens. And so, and you also know about the data we have for that pretty much making a difference. And so the question, I think some people, I don't want to say everybody, but a bunch of people are here, what do we need to do to reassure our surgical colleagues in that space?
I think we just need to jump the gun and just do it. I think we just keep, I think we have to do it and probably see that the rate of thromboembolic events is going to be just the same, and just be reassured by doing it. And I'm getting there. So, there's different things that could be done. Again, You'll have for sure a vaginal packing after you have a canal that's dissected, because there's usually use of a skin graft that needs to be so it stays in place for 5 to 7 days, depending on the different teams. For us it's going to be 6 days actually. And then when we talk about vaginoplasty, the most common procedure is the penile inversion. You're going to use the penile skin to reach a certain level down, and then you're going to gap whatever is needed to line the canal with different options. So when people say, well, I have peritoneal vaginoplasty, I don't want a skin graft, it's not necessarily completely true, because everything starts with inversion of that penile skin, and then you lengthen whatever is needed with either a peritoneal flap or scrotal skin, etc. We use the scrotal skin at GRS, and I'll show it to you. So this is the positioning, patients in the stirrup. You do the markings. That's the clitoris marking here, and then we'll keep all the pedicle nerves, artery, and vein here attached, of course, to this, so you could live as the clitoris after the procedure. We do use epinephrine, so it lowers the bleeding risk, of course. And then we start by harvesting the skin of the scrotum. That's then it's going to be defatted and prepared and thinned out on the back table by the nurse, so we can use it afterwards. You deglove the penile skin completely. You're getting that skin ready. Now you are ready to move, actually, so remove all of the part of the penis that you don't need. So you've been dissecting off all of that pedicle on top, urethra on the bottom half, okay? So you have this pedicle up, the urethra down, and then the cavernosal body, then you can get rid of this. This is the penectomy that you're doing. And then you can inset your neoclitoris. It was long, so the clitoris is here, so you need to fold it on itself and then attach it to the stump of the penis here, okay? And the urethra, what we do is we have this tube coming down, we split it open, so have a nice pink, shiny, almost self-lubricating layer that you can tack down and pass your clitoris through. And so the urethra is going to be the labia minora, okay? One downside of that specific type of procedure is that the minora is not going to loop around the vaginal cavity. It's going to stop at the meatus, the urinary meatus. So that's important to mention to the patient before. And so you see this is the penectomy again. You see that we'll keep all of this attached. We'll keep this. We'll get rid of that. And then comes the cavity dissection. You want to be between the prostate and the rectum. That's really the dreaded part of that surgery, because it's very thin layer. You can get very easily into the rectum and have issues such as rectovaginal fistula that it could be very hard to treat if you get that. So you want to recognize that very early, but you want to make sure that you don't get in there in the first place. So knowing the anatomy, placing the table in a certain position, using with a front light, for example, is gonna help mitigate this risk. And then once you're in the right plane, it doesn't bleed as much. And then once you're past the prostate, you can actually do blunt dissection and then extend the canal there and have a pretty good width as well. If it's still tight after you're done with that, then you have to release some of the levator muscles, which can cause chronic pain, in which then physical therapy, pelvic floor physical therapy is definitely going to be a huge add-on after. And I believe even that if you have the possibility to send your patients pre-op, you should send your patients pre-op so they can get in touch with their therapist and see what they can expect after surgery. And this is the lengthening again of that skin that you see. So here now we're putting that skin back on the mold and we're suturing in place to the penile skin, and it's ready. Now the tube is getting created and you're ready to put it in the vaginal canal using then a stent that's going to be placed in there and held in place like this for a few days until the skin graft has healed and is in place. This is the type of results we can get. Okay, so that's the difference between peritoneal and dilations. You have a dilation schedule. It's, for the body, quote unquote, it's going to be considered as a wound. It will try to contract. It will try to close on its own. So you want to dilate. You want to have a pretty strenuous, actually, dilation schedule at first. It's a full-time job, like patients call it, to make sure that you don't have that closure. If you do have stenosis, it could be at the introitus, the very opening of the vagina, or a little bit deeper. You could re-intervene, but you have to wait for a few months before you can do anything there. Those are the kind of dilators we use. And pelvic floor therapy. I cannot say, enough good things about pelvic floor therapy. I think this is a very important point. This is just an example of schedule. And again, this is it, the dilation process. Complications, bleeding, definitely, and it's important to see because this is one of the main complications we can have after vaginoplasty. This is what it could be looking like just a couple days after surgery. You got to go back in there, fix some of the small arteries, the bulbourethral arteries that could retract. You want to go and ligate them. It's very impressive, but it heals well afterwards if you get, take care of the problem. But it's important to see that. Dehiscence also at the posterior fourchette. You will have some level, we just have done a study, 85% of patients undergo some level of dehiscence there. This is a very bad one. But again, wound dressing is gonna do it. You want to have your patients dilate during that time because otherwise, the more it's going to close the cavity at the same time. So you got to treat the pain, you got to give xylocaine gels, for example, so you can keep dilating while doing that. Partial necrosis of the labia. Maybe because of a dressing, maybe because of a poor perfusion. I think so. We went over the feminizing surgeries, but we see each other again for a full hour in about an hour. So what I suggest is that we'll go over the masculinizing to start with the next hour, and then we'll go over a few cases. Is that okay with everybody? So we stay on track? All right, thank you.
Great. Can we have the primary care slide deck, please? I'd like to introduce, hello. You have access to all the slide decks, but we have taken the pictures out of the surgery decks because we did not want anything going out and to protect patient confidentiality. However, if there are like line drawings, and Netter's anatomy, we've kept that in. Thank you. And I'll turn it over to my colleague, Dr. Jenna Slovis, to talk about primary care. Thank you.
Hi, everybody. Thanks for joining us this afternoon. Full disclosure, I have to admit that we have a nice brand new slide deck for advanced primary care that I'm just getting familiar with. And I'm going to give you the research, don't worry, but I am a big proponent of when I go to these conferences, I'm like, okay, what am I going to take home and actually change my clinical practice with, right? And let me see all those primary care peeps in the house again. Right, so I know what you want to know. I get those 80 Powers emails every day. I hear ya. I get it. So I am going to cheat a little. I don't like to use notes, but I am going to cheat a little because there's a lot of points that I want to make sure that I don't forget to say as we're going through this deck. So I'm Jenna Slovis, she, her pronouns, and I'm the medical director of our multi-specialty transitions clinic in Oakland, California for Kaiser Permanente, and I basically have a gender diverse practice of all of Northern California because we like to split between Northern and Southern California. Northern being better, but I didn't say that. So I do a lot of hormones. I do a lot of primary care in our clinic. I work with a lot of different specialists as well. And basically, I teach medical students, residents from University of California, San Francisco, and our own internal medicine and gynecology residencies as well. So when we're talking about primary care, it's one thing to create a safe space for people. Oh, here's my clicker. Thank you. Okay. Oh, I have no disclosures. So we're going to learn evidence-based preventive and clinical care recommendations, specific concerns, non-medical gender affirmation, which is huge because your patients will not talk to you about these things, right? And so we want everybody to feel really comfortable. We know primary care, they come to us with everything, right? And so we want to make sure not only that our patients feel comfortable bringing things up, but if they're, takes a little time to establish rapport, and if we're thinking, well, I, kind of want to say this, but I don't know how receptive my patient is going to be, I want to sort of maybe hopefully give you all some terminology. Maybe you can help teach me as well to help folks feel more comfortable. So we know how important it is to create a safe and welcoming space, right? What does your waiting room look like if you're still seeing patients in person for the last couple of years, right? Are there gender neutral forms? Do posters and magazines really reflect the people who are looking at them? If you are in more of a gendered space, like some of our OBGYN colleagues, do you have ways that people who might not feel comfortable sitting in a waiting room where they might not necessarily look like other people in that waiting room, right? Do you have other ways they can register somewhere else, maybe come through another door? Again, be thinking of these things, because these are all things that, like, if it doesn't work from the get-go, your patients are not going to come back. And not only are they not going to come see you when they feel sick, but guess what? All those wonderful things we try to do in primary care, right? Those preventive screens, prevent those cancers, prevent that cardiovascular disease, it ain't going to happen because they're never going to come back and see you again. And it just takes one bad experience for people to lose all that trust, right? We've had so many years where the medical community had no interest in taking care of gender diverse people. No wonder people turn to Powers and Reddit. No wonder people are like, coming to us with all sorts of mistrust, I'm not going to tell you I smoke because you're not going to let me have my surgery that I know I need, right? So we need to create this space where people understand we care about you, we want to listen to you, we have your best interests at heart. We're going to think of harm reduction models rather than say, no, we're not going to give you these things that, by the way, every time, one of those articles comes out about another blood clot on estrogen. Well, guess what, right? That's not what our patients are dying of. We're going to talk about that. And the truth of the matter is, giving people access to gender-affirming care is suicide prevention. Period, right? That's it. And for our kids as well. I don't even want to go there. Thank you. So anyway, creating safe spaces. But we also know that it's not about safe spaces, right? Because we can give our medical students, our residents, click off these boxes, right, when you're seeing people. And we know that prejudice and discrimination and harassment still exists in the medical setting. Our patients have experienced it in the past. They experience it again now as we're saying, come to us, we have all these wonderful evidence-based guidelines, trust us now. And they're still experiencing bad experiences. So we need to make sure that our medical students, our residents are, not continuing the pattern of discrimination and harassment, and we need to have zero tolerance policies, and they need to be well displayed, and we need to make sure that our patients feel safe and trust us so we can actually give them the care that they deserve. Okay. I think a lot of it also, an experience that I often have in my setting is I work for Kaiser, big conglomerate. But basically, someone comes into my system, they had another insurance, now they have Kaiser, and I see this all the time, right? I just ran out of my hormones, or I couldn't get my refill, whatever. I was halving my doses because I knew I wasn't going to see you for a long time, right? They come into an urgent care center, a primary care center, and it's like, okay, great, yay, welcome to Kaiser. We love gender diverse people. We're going to take good care of you. You're on hormones. Oh, gosh, I don't know anything about that. I'm going to send you to endocrinology, or I'm going to send you to the transgender clinic. And, months later, they miss their appointment, right? So hormones are gone, right? Everybody's in instant menopause or menopause. They're feeling horrible. And you know, when I say to my students or whoever, I'm like, well, why didn't you give those refills? I don't know anything about hormones. I want to make sure they got to a specialist. And I'm like, yeah, but you know, if this person was diabetic or if this person was on high blood pressure, like you wouldn't have questioned that. You would have just given them the refill. Okay, you don't have to give them a 100-day supply, but you would have given them enough of what they're taking, because guess what? They've been on it a long time. You're not going to do anything bad. You know, you just would have given them that refill and gotten them set up with care, and there you go. And great, if it's not your expertise or you don't want to know more, that's okay, but you wouldn't leave them hanging, right? So if you don't know something, that's okay. Look, you're all here. You're the people who are going to be teaching this, right? So that's why you're here. So you're going to get that expertise. And if you don't know it, fine. At least take care of what they need, where they are now, and get them to somebody who does. And make sure it doesn't get dropped along the way, right? Think of COVID, how many appointments got canceled, how many people lost access to their meds, lost access to their insurance, okay? So those little 1 ml vials, oh, you're damn right I'm telling people to use as much as they can, because I had so many patients who lost their jobs and lost their insurance with COVID, and I'm just trying to get them through as long as I can until they can get set up with whatever care they can get set up with. Okay. All right, there we go. So let's talk about, this is an updated study. One of these first mortality, huge mortality studies was presented like 10 years ago. And it's what gender diverse people on hormones are really dying of. So yeah, we see a little cancer. Yeah, we see, some heart disease. But the truth is, overwhelmingly, people are dying of HIV, suicide, and drug use. Okay, very, very statistically significant, especially for transgender women using hormones. And this study was updated, this landmark study was updated 10 years later, so this is the update, and guess what? Still the same info. No big surprise there. So are hormones killing people? No. Societal discrimination is killing people. And this is modifiable. So if we can fix how society treats people, and I argue if we can give people access to gender-affirming care, which for many people is going to be hormones or surgeries or whatever care they need, then people are going to do better, okay? So that's kind of all I want to say about that one. Because, right, it's every freaking, and I got the emails when, I don't know, like a year ago or so, there was another article about, blood clots and estrogen and 2 times the risk. And I'll tell you what my counseling looks like when it comes to that, which, thank God for Dr. Deutsch. I just copy everything that she says, and I feel so much better at the end of the day. Okay, so what can primary care do? I think there are some basics of what a primary care physician can do. That's showing what people are dying of. Okay, so I think there are some basics. And yeah, we do a lot in primary care, right? I get those 50 emails a day, and I swear to God, I'm sitting here right now with like at least 2 emails in my inbox that came in over the past 2 days about BICA, progesterone. I heard Spiro's gonna kill you, right? I hear it all. But basically, I think for primary care, there are some basics. Stable hormone refills. Easy. Someone's doing well, great. Continue their stable hormone refills. Annual labs, we heard a lot this morning about what labs should you check. Some of that depends on what kind of system you're in and how much access you have to labs, quite frankly, and what your lab levels are and things like that. But some typical annual labs, which I would argue in any adults nowadays, we are checking a lot of pretty typical labs. Why? Because 70% of adults are obese or overweight, 1/3 of them are pre-diabetic. So we are looking at cholesterol and blood sugars and things like that anyway, whether people are on hormones or not, quite frankly. Some of the other things, the preventive screens, and we're going to talk about really how to get this right, because this is a big, big, big problem area, especially with electronic medical records, which are like prompting you, hey, your patient is due for this, and it's all gender-based, it's female or male, and I'm telling you nowadays half the times it's wrong. And if you don't know that, you're going to be telling your patients the wrong recommendations, which is really even worse than not telling them any recommendations at all. And if you want to go further and you want to, deal with some of the complicated things about hormones and, some of these, God, should I use progesterone? Should I do this? Should I add finasteride? I don't know. Well, you all are here today. And so you are the people who will be doing these things. And thank you, because you're going to be teaching your fellow primary care providers as well. So what's really important? SOGI, so important. Sexual orientation and gender identity. Now, during the Obama era, this became a requirement for electronic medical records. But then a little something happened after Obama was president in the US, and it kind of like never made it to the next level, which was actually requiring that medical providers would actually enter this data. So we've been stuck for quite a while. I'm sorry?
It also doesn't include the clitoris.
Ah. Thank you. And this will vary, actually, by different medical systems and things like that, what this looks like. So basically, what's the power of SOGI? Okay, well, first of all, to decrease misgendering. Because what you don't see on here is often what also comes along with some of these SOGI questions, which is, what is your patient's chosen name? What are the pronouns that your patient wants you to address them by? And in some systems, maybe even offering updated photos, which can be really nice for people, especially if they look different over time. They might want to update that photo. It also helps us with population research, right? So if we don't know who our population is, we can't begin to identify health disparities, which means we can't even begin to fix those health disparities. So this can be really helpful there, and it's not super dependent on what someone's gender identity is. And then the right screens, which is life-saving. And I'll tell you, in my own organization right now, we're looking at SOGI, and we've been really good about, or I think we've been really good about trying to train providers to, ask people their names and ask people, what were you assigned at birth? What is your gender identity? And we do have fill in the blank kind of options as well for folks where they don't feel that whatever we're offering them fits. What we haven't been good at is this damn organ inventory. And we are really struggling trying to figure out, how do we engage people? These are really, all these questions are very intimate and personal, right? So is it something that you email somebody? Is it something that when someone is coming in and they're going to reception and the reception's like, hey, what organs do you have, right? We know that doesn't work. And so trying to kind of figure out what is best going to engage people and make them feel comfortable. We know from UCSF, people overwhelmingly, and all the studies that have been done, overwhelmingly, cisgender people too. We should be doing this for everybody, right? That's the only way we're going to normalize it, if we do it for everybody. We know that people overwhelmingly prefer to just do private self-entry kind of stuff. And if you don't have the ability to offer somebody a form or a tablet or an email, then if you're sitting in the exam room with them, you can pull up the screen and say, hey, I asked this of all my patients. This is how I'm going to be sure that I know what organs you have, so I know what medical interventions or screens are appropriate for you. I want to get it right. I don't want to put you through something that's unnecessary or wrong. So when we look here, can you tell me which organs, blah, blah, blah. And then this way we do it together, can feel a little safer. We're struggling how to do this by email, right? Because with COVID, I'll tell you, the majority of my care over the past 2 years has been virtual. And so we are still kind of trying to figure that out. And of course, ask your patient if it's okay. I have some patients who say, I don't feel comfortable with this being in my chart. I get my health insurance through my employer. I trust you here in the office, but I don't know what my employer can see, and I don't feel safe. And that's okay, and that's all right. And I just try to think of other ways that I can make notes for myself or for my colleagues who might be looking at my notes or the chart, where I can honor my patient's identity and what name or pronouns they want, but not out them in ways that feel uncomfortable, maybe by a diagnosis or something like that. So it's going to take some thought, and you do need to talk to your patients about it. Any questions about organ inventory or comments?
I do have a question. So my mom is actually a cytotechnologist, so she looks at pap smears all the time. And she actually called me the other day and
Yeah, we're going to talk about that.
Yeah, great.
Yeah.
I'm a huge proponent of organ inventories, but not as they're like laid out in EHRs. So I used Epic for a long time and given a lot of feedback. And I'm just gonna make this is comment, not question.
Sure.
I find that organ inventories, personally, I don't clearly understand why they are related to sexual orientation and gender identity necessarily. I think they should be disambiguated. That's not SOGI data. That's health data.
Right.
It's health data for everyone, regardless of sexual orientation or gender identity. So it's like one comment. And then I think that's a universal reality. And the other is that these like categories, regardless of if yes, there's missing clitoris, fallopian tubes, and like the opportunity to clarify if patients have ambiguous genitals or intersex genitals. The enhancement surgically, hormonally, are biasing language that make this suggestive of being only about like gender diverse or like queer people, and not about like what it means to have organs or not have organs. And then my third comment is that I go through this information with all my patients. Also am clear with them that like if they don't know what I'm talking about when I'm bringing up different names, that we can clarify that together and ask questions about like, well, have you ever had a period? Like, do you have if you have ovaries and a uterus, like you probably have a cervix and a vagina. Like if you don't know if you have a prostate, let's go back to that one.
Excellent.
So like, I think it's really challenging when EHRs integrate these organ inventories in here in the way that they do, and then also create a space where even we, have no clear idea of how to do this in a patient-centered, trauma-informed way and affirming way. And that is like our responsibility, I think, as clinicians, and especially clinicians in this space.
Thank you so much. Those are, yes, 100% agree. Thank you. Juno?
I'll just put out a plug that we're trying to do an evidence-based approach to developing organ inventories, and we have a session on Tuesday about some of the work we've done on that.
Great, great. And for those of you who might be a little like, well, I'm like, I don't really get this organ inventory thing. In some systems, and I'll give you an example. So I'm in Kaiser, and what happens is we do a lot of prompts to providers to say, hey, you're seeing this patient, and did you know they're due for a cervical screen, or did you know they're due for a mammogram? And our EMR is prompting our providers by what the gender marker is in the chart, which we know might be wrong and might not speak to the organs the person actually has. So we can miss screens that people might be due for, or we could be telling people they need screens that actually they don't even have those organs. So the hope is that by filling this out, it's updating those prompts to providers so they're not just doing the sort of the wrong gender kind of stuff. So that's where that says, but you are 100% right. We have so much further to go.
But also, like, the clinical decision aid tools in, like, Epic aren't tied to the organ inventory. So even if you have an updated organ inventory, it's still going to leave things, like, if the patient's never had a cervix, never going to have a cervix, like, you still get half years coming up, and you still have to,
Right.
like, postpone it for, like, 20, 30 years so that it never shows up.
Right. So in our system, we did an overlay that says congenital absence of cervix that I can click, like for my trans women kind of thing, or people who don't have cervixes. Or I could do hysterectomy or mastectomy. Imagine that. Right. Right. Thank you. All right. And how you're going to fix that? We're gonna, and this is great because it's just so many of these things are just little beginnings.
Just a quick one. Our Epic says born without a uterus is an option that we can use for our patients.
Yeah.
Okay. Right. Beautiful. Thanks. Okay. Well, let's move along. Let's move on to some of these screens, which shouldn't be a huge surprise to you. And we're often telling people that basically, if the person has the organ, it needs the care. Period, right? And so at the end of the day, if you just kind of think of that age and risks and whatever you would do with cisgender people who have the organs, for the most part, it's going to be same for your gender diverse people. When we're talking about people, sometimes with top surgery, if someone's had a reduction, like how much tissue's there, it gets a little more squirrely. But certainly, we're saying if someone hasn't had chest or top surgery, follow the same guidelines. And again, depending on where you are, depends on what guideline you follow. And that's usually what we're going to say at the end of the day. If someone has had surgery, and again, we are assuming the majority of the chest tissue has been removed, and we're thinking of this more like, a normal risk person, and they might have, if there is any chest tissue left, it's sort of like the same amount as cis male might have, and then we don't often say we do screening mammograms in cis men. So again, that's where kind of this recommendation about maybe no mammograms comes from. It gets a little tricky, I think, when you're talking about should people be doing chest exams, clinical breast or chest exams. Depending on who you talk to, you're going to hear different answers, right? Because we're sort of, in one hand, we're moving away from these exams. And part of that, too, is it's an equity issue as well, right? So if you have a low-risk population and then you're kind of telling them to do more things, which of course people are going to find lumps and they're going to get more anxious, and the majority of those lumps are probably going to be benign, right? And so why are we telling why are we telling one population to do more sort of that can lead to invasive screens and biopsies and more, anxiety and worries that we wouldn't tell a cisgender population, right? So we have to be thoughtful, but it is true, right? I mean, if a patient has had top surgery and they're feeling their scars and they feel a lump, what do you do with that? Well, yeah, of course we're going to treat that no different than we would with anyone who had an abnormal finding. So again, no clear recommendations, but the majority of these really are following that. Plus also recognizing that, we don't have mammograms and not everybody has access to MRIs and, and other things like that. For trans feminine people, we're often thinking that, to have an increased risk of breast cancer beyond that of a typical cis male, you have to have some estrogen stimulation, right? And so that's why some of these guidelines look at like 5 years of estrogen use or 10 years of estrogen use, and this does not have to be consecutive either. So that's an important point. So if someone says, hey, 20 years ago, I had 3 years of estrogen, and then I lost my insurance, and I fell out, and I haven't had estrogen, but now I'm back on estrogen, and it's 2 years later, and I'm the right age for screening, then we're saying, yes, screening should start. Like we wouldn't, start brand new and say, oh, now you need 5 years. So it's, again, these are subtleties. Do we have any research saying? No, we don't. But again, we're kind of going by this just because we're trying to look at, well, when does risk start to increase? And if you want to look at, and basically again, every 2 years, over 50, that's USPSTF guidelines, but again, I say use whatever guidelines at your institution or whatever your field is to guide you. When we look at rates of breast cancer, this is I think where the meat is. And it's very reassuring. So we have the Brown study, which was a VA population of about 5,000 people. We have the Dutch cohort. There's issues with the Dutch studies because they actually kind of looked at rates of breast cancer in a general, in gender diverse people in a general population that had breast cancer rather than like a general screened population. And then on the right, you see the expected rates in cis men and cis women. So take home, yay, we see lower rates, right? We're seeing rates in trans men and trans women more similar to cis men. So that's really reassuring, okay? But what's interesting, and what we learned from Brown, is that when people did show up with breast cancer, they showed up much later with much more advanced disease. And so again, it brings you back to what are the health disparities? What is really making people sick? And the question is, did these patients not go for their mammograms when they were supposed to? Did they not even know that they had breast tissue and they were on hormones and they were supposed to get mammograms? Did their providers know that they were supposed to get mammograms? And we just don't know. But again, I think as the theme of this lecture is going to be, at the end of the day, it's the health disparities, it's societal discrimination, and maybe providers or patients just not knowing the care that they need to make sure that people are getting the right care and not like, the hormones or anything like that. Okay, and of course, if there is a problem, right? I have a patient who's BRCA, I'm sending them to genetics, right? I'm gonna get guidance because that is what I would do with my cisgender people as well. And of course, if there's a lump or another concern, you're going to treat that no differently than you would anything else, because we are at a screening for there. Okay. Cervical cancer screening. All right, here we go. So if you have a cervix, you need screening. Okay, so number one, trans women or trans feminine people do not have a cervix. They were not born with a cervix. They do not get a cervix in surgery. And often they will get those outreaches that say it's time for your PAP or it's time for your cervical cancer screening. And if your system automatically tells people that they need that, while some people find it gender affirming and nice that they're getting outreach, it's an unnecessary invasive exam. So let your patients know that and get them out of those outreaches.
Yeah, because we have to take into account right now those patients that are having a transplant of uterus.
Good point. I have not had a patient get a uterine transplant. Yeah, so.
Five in Brazil, two in Mexico.
Oh.
In Mexico, actually.
Yeah.
So we have to take into account.
Beautiful. See? So as things increase, we might start seeing more different recommendations. Thank you. Thank you for bringing that up. Uterine transplants. Super exciting. Okay. For people who have a cervix, they need screening, whatever that looks like. And we just had last year the American Cancer Society, USPSTF in America, said that HPV screening starting at age 25 every 5 years. And we have lots of studies now out of wonderful clinics telling us that self-swabs are just as good as those in-clinic swabs and can be a wonderful method for patients who don't want to have those invasive exams in the office.
I just want to make a comment. At my clinic, I'm at the LGBT Center. We had a 14% unsatisfactory rate
Right.
for our cytology specimens, and we were using FinPrep. We switched to SurePath and leaving the cytobloom in the vial, and they went to 0%. Quest really taught me on that because they have an agreement with FinPrep. They didn't want us to switch. We did, and it went completely down. We're also doing self-swab right now, and we're including cytology to get a sense of how many are getting the transformation zone. And we're finding that like 75% we have the transformation zone. And the reason is Quest won't, so if you send an HPV, Quest won't reflex it to cytology unless you're using FinPrep. So they were going to make us switch to FinPrep, which would undo everything we've done. So we're sending co-testing because it was really hard. We were sending primary HPV, and then I'd have to call the lab to add on the cytology, and it would extend too long. But it's working on both fronts with those two changes.
Great. Thank you so much. Yeah. And take home with this is, I think this is a no-brainer. Like if you can even mail people these swabs like we do now with, colon cancer screening kits, people can do it in the privacy of their own homes. Like they're much more likely than to maybe want to engage in that than rather come into the clinic, have this really invasive exam, which can also be traumatic, since a lot of folks have trauma histories. So again, being thoughtful. And I should make a point. So we do hear about this PAPS being 10 times likely to be unsatisfactory. We know that with testosterone, there's atrophy, mimics dysplasia, right? And yes, we put notes. Hopefully you're putting notes on your PAP saying this person is on testosterone, this person is amenorrheic, but still there can be unsatisfactory readings. There are some practices which actually are having, before a patient comes in for a PAP, doing 2 weeks of topical estrogen, or if the PAP is coming back unsatisfactory, then recommending the patient do 2 weeks of estrogen before coming in for a repeat, which we don't want to make people have to do repeats. But certainly, I think there's a lot of ideas going on and how people are trying to get better rates so our patients don't have to be subjected. Take home again is we know there's huge health disparities here, and already our patients don't come in for exams, or there's really long lag times between them coming in at the intervals they're supposed to, or if there's abnormals, doing follow-up. So again, anything we can do to be supportive to help our patients get those exams is always going to be the take-home. Zill Goldstein was actually telling me at Kaylin Lord They're doing a lot of HPV self-swabs, but again, new learnings, right? For patients who are having hysterectomies, the surgeons are requesting cytology within 3 years. So a lot of those patients are having to repeat cytologic exams. So again, this is learning as we go along. And trying to help out there. I'll tell you, at my own institution, we're not at self-PAPS yet, but I thought, I've got HPV swabs here. I'm just going to give them to my patients when they come in, and they all got thrown away. No matter what I put, the lab was like, nope, and tossed them. And you can imagine how embarrassing it is to me to have to go back to my patients and say, sorry, we're not there yet. So, yeah. So again, you got to see what your institution can offer and go from there.
What about the bimanual exam that you're not doing with that?
I don't do them. Bimanual exams, yeah, I don't routinely do them. I mean, if there's a problem and you need to check something, but as part of routine cervical cancer screening, don't do them.
So you're really getting vaginal swabs with self-swabs rather than cervical?
The thought with HPV is wherever that swab is going, it's getting enough that it's good enough as what you would get in the office for screening purposes. And I don't know, does any of our OB/GYN folks want to comment on that? Or?
I believe also new cancer recommendations is that 25 and above is HPV only.
Right, right.
And now, more institutions are following in line, but I think that's the American Cancer Society.
Okay, great.
Yeah, the only observation further is on your theme, Jenna.
Uh-huh.
Of what are the harms and what are the disparities.
Right.
So at Sinai, we've actually had a couple pilots and then we got messed up by COVID, so we have to go back to it, of doing some self-swab. And the main thing is let's just accept that it isn't quite as good, that it's 80% or whatever, because that's actually what those statistics are. It's not like terrible.
Mm-hmm.
And then, but the numbers of our trans guys actually doing it double. And so we're gonna, if you're thinking of screening just from a population health perspective, that's twice 80% is better than.
Okay, all right. So I'm going to move along because I've got a lot to get through. Sorry. I knew we have way too many slides. I also want to put in a plug. We're never going to withhold care, right? Just like if somebody's a smoker, doesn't mean they can't be on hormones, right? You're going to want to be more thoughtful of how you're going to do hormones, right? So with estrogen, maybe I'm going to do a patch, or maybe I'm going to do a lower dose, right? But I'm not going to say, no, you can't have these hormones. Okay, so same thing. Again, whatever we can do to be supportive of our patients is super huge and important. And of course, no evidence of any cancers, period. If someone is on testosterone, they're not bleeding, yay. If someone is bleeding, did they run out of their med? Did they lower their dose? Has there been a change? And if so, you don't have to worry about it as long as it corrects once things are fixed. And certainly someone has been on their testosterone and they haven't been bleeding forever, and all of a sudden they're bleeding and you don't have a reason, then yes, you need to look at that and treat it no different than you would somebody else who shouldn't be bleeding. And I just want to put in a couple of plugs for trauma-informed care. Again, when we have to bring patients into the office, and this doesn't matter if you're doing a genital exam, I would argue, chest exams, listening to the heart, listening to the lungs. People have binders on. People are sensitive about these areas. So you always want to ask permission. And if your patient is like, nope, please honor that. It's more important to develop rapport so your patient will trust you and come back to you, okay? Especially if they're not there for things that feel really intimate and invasive on their bodies. Again, safe spaces. Can people leave clothing on? Right? Does somebody have to get completely naked? Do they want a support person? And I don't mean your assigned chaperone or your medical students or your residents, right? Now, often I will say to my patients, like, look, I've got this medical student. They're so interested in learning from our gender diverse patients, because my generation didn't have that, and I want to make sure that other gender diverse patients are going to get excellent care. And do you mind if my student comes in, and if my patient says absolutely, yes, we want to make things better for other people, fantastic. And if they say nope, not today, That's fine. You can go read an article, and I'll come back and I'll talk to you about the patient when we're done. Okay. For pain of genital exams or, speculum exams, little speculums, a benzo, topical lidocaine, music. Do they want you to tell you? Do my patients want me to tell them every single thing I'm doing because I tend to be chatty, or do they just want me to shut up and they want to listen to music or talk to a friend, hold hands, whatever? And again, I think the whole chaperone thing. This came up recently because at my institution, there's this. We have to have a chaperone. We're afraid the patient's going to sue us, kind of thing, if we don't have a chaperone in there with the provider doing the cervical cancer screening. And some of my patients said, then I'm not coming in. And it's a little tricky because they're like, yeah, but it's required. And it's like, well, I'd rather my patient get the exam, bring in a friend, and I trust your friend, and there you go. So again, I think we just kind of need to be a little thoughtful when our institutions are putting up these rules that to our patients, it just feels like discrimination and that we're not honoring their wishes. Okay, we talked, so again, here's the guidelines. You can go by whatever you do. We already talked about this. I think this article was already up this morning. Take home, yes, people who have sex in ways that can result in pregnancy can get pregnant. There you go. That's a take home. And not all bleeding will stop on testosterone. And what I often say to my patients is, look, I will get you to your happy place. And if you stop bleeding, then great. And if you don't, and you're in a good place and you're happy otherwise, and we don't have room to further increase your testosterone, then we'll talk about all the other options, which is basically anything. Quite frankly, even birth control pills. I've had some people come to me, they're like, I've tried everything and now I'm on birth control pills because I get horrible whatever, and it's the only thing that works for me. Okay, fine. That's okay. We'll stick with that and we'll put you on testosterone. Fine with me. The other thing, a big plug for LARCs, right? These long-acting things. It's not just, if you have access to them, Depo-Provera shots, IUDs, implants. I also think about it this way, like what if somebody loses their insurance, right? This is a wonderful thing rather than daily pills for some people, even though the pills can be quicker at stopping menses, I get that. But the other thing, too, is they're very concealable, right? So people don't have to worry about their roommates finding things or being outed. And so, again, a big plug if you have access to those things that they can be really helpful. Prostate cancer screening. Shared decision-making, which essentially, I've heard Maddie Deutsch say this, just means whatever the provider tells the patient they recommend. I don't know. I think the main the take-home with prostate cancer screening is there's been 7 to 9 cases in the literature of people who, on feminizing hormones, were later identified with prostate cancer, and it really is thought that the majority of these people had prostate cancer early on. Their hormones were started, so that's where some people would be like, okay, if my patient is 50 and I'm just starting feminizing treatment, I might get that baseline PSA. And I actually just did have this with a patient the other day. They had a really high PSA. And so I sent them to urology to, make sure there wasn't any cancer or anything like that. And then, great, that's cleared. Now we're going to start your feminizing hormones. Because we know that PSA is going to go down. Some people use an upper limit of 1 as normal. I've heard ASA say a third to a half sort of a typical PSA might be what we would look at. That's kind of the main thing here. I think the other main take home is, how do you examine a prostate if somebody has a neovagina, right? You're gonna, if you have a reason to feel it, I guess you're gonna feel it through the neovagina rather than the rectum. And patients need to know they have a prostate, right? It is not taken out in surgery. And a lot of people think, oh, I had my feminizing surgeries, all my, quote unquote male bits were taken out. And they don't even realize that they have a prostate. And then someone goes to the ER for abdominal pain, and all of a sudden they're told they have this metastatic mass, which actually is a normal prostate. And this happens all the time. And I guarantee you, even if you put on the requisitions, this is a transgender woman or whatever, the radiologists still miss it. I had a patient the other day who had a CT scan, transfeminine status post vaginoplasty, a very long time ago, and I looked at the radiology note. She had some abdominal pain, and it actually said small uterus. And I know the radiologist was just using their female template, right? So again, think of templates, folks. Really important. Okay. All right. Let's go in. No cancer. Okay, colorectal cancer screening. There's nothing gendered here. The only thing you need to think about is if someone has had a vaginoplasty created with colonic mucosa, then if they have problems or if they need to get their screens, the vagina needs to be scoped as well, because they can get polyps and colitis and all sorts of stuff like that. Anal paps, still no clear guidelines here. Obviously, people who are higher risk populations, HIV positive, men who have sex with men, or trans women who engage in anal sex, people who already have dysplasia, gynecology dysplasia, immunocompromised, right? Those folks might be higher risk. And in fact, they say that with anal paps, the risks of anal dysplasia and anal cancer is actually kind of the same in high-risk populations as it was before we started doing cervical paps. So there's an argument there, like, hello, we need to come up with some guidelines for folks. I would say the biggest issue we see really is that with anal cancer, people are just kind of showing up once it's a bit too late, right? Because you don't know you have anal cancer until you do, and when people are symptomatic, they're going to the oncologist, and the oncologist is like, what is going on? How come nobody is screening my patients who now have anal cancer that, we could have identified when it was just dysplasia and treated it? And it's because we do not know what to do, right? So again, a big plug for, you can be affirming and you can be welcoming, but if you don't know what the risks are of your population and how to address those risks, you're going to be doing the wrong care. Okay, so our folks who are engaging in anal sex and are higher risks are not getting this kind of care. And so what does that look like? Is it a specialty clinic? Is it a primary care office? We don't know, but y'all figure that out. Okay, osteoporosis screening. At the end of the day, gender probably doesn't really matter that much. And I would argue that it's not my older folks that I'm so worried about developing osteoporosis. It's my younger ones who are having their gonads removed, or they're on like implants, Lupron, Hystrulin, Vantis, and they're not very good about taking their hormone replacement with those, because we know in our 20s, 30s, we're building the majority of our bones. And, if you feel fine, I'm forgetting to take my hormones, but I feel fine. And my testosterone is blocked or my estrogen is blocked, they're going to feel fine, and they're not thinking about their bone health. So the thought is, if somebody doesn't have gonads, or they're kind of fully blocked and they're not taking low dose, enough replacement, then you want to be thinking about screens, and what does that look like, usually about 5 years after, regardless of age. And some people will recommend minimum hormone doses like estrogen 2 milligrams or a 0.1 patch, or even a testosterone level of maybe around 300-ish. Some people will look at LH and FSH levels to see, because if they're elevated, it's kind of telling you probably don't have enough hormone protection. If somebody is on Lupron or GnRH agonist, though, you can't measure LH, FSH, and that was a mistake I made early on. Oops. And my patient actually said, did you realize these levels don't work when I'm on Lupron? And I was like, oop, thank you. So that's a big thing to remember. Okay. And immunization, same as everybody else. I do want to put in a plug, HPV, right? A few years ago, CDC set up to age 45. I still get pushback from providers when we're like, hey, this patient's interested in HPV immunizations. And the provider says, yeah, but the computer says it's only up to age 26. So no, I'm not going to offer it. And I think one thing to remember is, in my philosophy, if someone didn't get their childhood teen immunizations for HPV, a lot of our patients maybe have never even engaged in sexual activity with anyone. There's so much dysphoria. And when somebody actually can access gender-affirming care, again, whatever that looks like, maybe they start being more social, and they have more confidence, and they start having sex with people, and in ways that they haven't had before. And so we want to be thoughtful. Anything that can protect someone, why not? I mean, I had a 50-year-old who has never had any sexual activity with, other than one person since their 20s. And now that, they're in a different stage in their life and they're like, hey, I want to play the field. This is exciting for me and I want to enjoy my body in lots of different ways with lots of different people. And it's like, I'm not going to say to them, oh, you're too old for an HPV vaccination. Right? So again, be thoughtful about instead of all these guidelines, like what makes sense for your patient and protecting your patient. Okay. And then, just running through things, typical, again, we know, I think for me and my experience, any hormones, I don't care what hormones you're on, people gain weight. And even if you're not on hormones, as you get older, you gain weight. So I'm just, looking at what are the typical risk factors I'm doing in any gender of person, whether they're on hormones or not, and then I'm just supporting them where that is. So I do want to make a comment about weight loss because I think one thing we need to remember is there's a lot of bias here, right? We have patients who are denied surgeries because their BMIs are quote unquote too high. And we need to think, some patients, for example, let's say you have really prominent breasts or chest tissue. There are some patients who might gain a lot of weight to kind of hide that, right, discomfort. And we need to be thoughtful that, besides smoking, like weight loss is one of the hardest things for people to do, right? And stress and not having access, again, to gender-affirming care. There's a lot really working against people. And then you're telling people, oh, you need to lose a massive amount of weight to be able to have this life-saving gender-affirming surgery. And people develop eating disorders, and people go and get bariatric surgery to be able to qualify for other gender-affirming surgeries. And it's ridiculous. And so, again, we need to kind of support people and really advocate for people. And if I say to a patient, well, your BMI's high, and if you have top surgery, you might get dog years, and you might need a revision later on. I think my patient's going to say, I need that surgery now. I'm okay with that. So I apologize. I am being cut off because it's time. But you will get the slides, and you'll get all that information there. Thank you. And we'll just go ahead and take a quick question. Can you go to the microphone, please? Thanks.
This is not on. Where it is. There, on the Whova platform in the community section, there is a articles, like share articles section. And I wanted to mention that I've shared in the Journal of the American Medical Informatics Association, Maddie Deutsch's article from 2013 with regards to organ inventories in the EMR, and an updated article that was by Grasso et al. In 2021, I believe. So please do share some of the other evidence that you're seeing. If you could share it in the PubMed format so that people can access it completely, that'd be great.
Do you want to say that again? In the Whova app, correct? Whova Community Shared Articles. Thank you. Can we get the other slide deck, please? The primary care cases. Thank you.
So what we're going to do now is we're going to try to run through some cases, and so basically, Maddie, thanks for joining today, and I'll let you both introduce yourselves and who you are, and we'll go from there.
Hi, hello. Okay. Hi, I'm Maddie Deutsch. I'm a professor of clinical family and community medicine at University of California, San Francisco, where I'm the medical director for our gender affirming health program, which is our adult side medicine program, multidisciplinary program, and I'm the sitting president of USPath.
And I'm Erica Sullivan. I'm a family physician and an educator at a family medicine residency program at the University of Utah. And any errors in the slides are my fault, so please let me know if there are any, and we'll make sure that we get them changed for the PDF version that is coming out to you.
Great. And so what we've done with the slides is we've tried to pick some cases that we feel you're most likely to experience in your practices, and You know, and again, there's, as you've learned from the hormone discussions this morning, like there's no right answers here, and everybody's going, no, you know, I start with 50 and then I bump them to 40 for the testosterone. Some people are like, no, I inch up. And then some people are like, oh, my patient's like, and I will recognize, I would say in the past year, I feel like the majority of people who are coming to me for hormone starts have non-binary identities, and there's a lot of this language about microdosing, or I just want to dip my toe in the water and see how that feels. And again, it's just about conversations with your patients about their goals, realistic expectations, what you can do, what you can't do. You know, you can't promise. So I think that really, I think we're going to start seeing a lot more of that as people feel they don't kind of have to be in these boxes, which is really exciting. But also, of course, the internet is full of all sorts of promises and distractions, and we want to make sure, again, that our patients are getting the best evidence-based care that we can. So we're going to start. So our first case is, all right, we'll just get through here. This is Layla. And I'll just quickly read about it. So Layla's a 54-year-old trans feminine adult, she, her pronouns, comes to you to start gender-affirming hormone therapy. There's been gender incongruence since about age 4 or 5, but just, again, you know, never felt safe acting on it. Came out to family and community about 3-4 years ago, very supportive, socially transitioned about a year or 2 ago, and is coming to you now to start hormone therapy. And just for some of the baseline stuff with her, you know, 54 years old, has, you know, some DVT, pulmonary embolism kind of stuff, hypertension, hyperlipidemia, right? Your typical primary care patient. Diabetes, GERD, obesity, depression, chronic pain. We've got a whole bunch of meds, including our, what we love to call our heart vitamins and our anticoagulants and our diabetes meds. We've got some baseline labs that show, you know, the diabetes, some high cholesterol, stuff like that. And we've got, you know, some blood pressure, very exciting, typical stuff. Okay, so I guess the first question is, should you put Layla on estrogen? Or what would your recommendations look like regarding what hormone regimen you would offer? And Maddie? Do you want to start?
Sure, yeah. So I think the first thing I would do with this patient is what I do with any patient, which is to determine their goals, because patient goals can be non-aligned with their identity. So there might be a person who has a binary identity but wants sub-medically appropriate maximal effects, whereas somebody else may have a non-binary identity but still be seeking maximal medically appropriate change. So I would kind of first take this patient's, you know, kind of take a history or take an assessment of their goals. You know, I think that the cut to the chase with a patient like this, they're on apixaban and they've had multiple clots, they're factor V, we know they're a clotter. You know, this whole estrogen causes blood clots thing is, I feel like it's like Budd-Chiari syndrome or one of those other like internal medicine pimping rounds questions that doesn't, that if you manage somebody's hormone therapy properly, the incidence that you're going to see in your clinical practice of thromboembolism is going to be very low. And if you look at the data going back into the 80s on venous thromboembolism with the administration of gender-affirming hormones, the data, the studies that showed these 20 to 40-fold increases, those patients were using 7 to 10 birth control pills a day worth of highly thrombogenic ethinyl estradiol, which is a synthetic estradiol found in oral contraceptives. The reason it's used is because it's very effective at preventing breakthrough bleeding, but we're not worried about that when we're doing feminizing hormone therapy, so we use 17-beta estradiol, which is the same stuff used for menopause preparations or for people who have like Turner syndrome and things like that. So when you look at the thrombogenicity of estrogen, primarily it has to do with a tipping of scales of creation of certain clotting factors in the liver during first-pass metabolism. So oral estrogens in general tend to have a somewhat higher risk. When you look at the data for oral estradiol in the menopause literature, which are potentially at lower doses than you might see for somebody who's a premenopausal age trans femme person who's going for feminizing effects, the risk of VTE, absolute increase, relative risk increase is 2 to 4-fold. So, you know, that's it sounds like a lot, but when, you got to look at the number needed to harm, right? So it's probably not that much. But the menopause data and the existing data that we have in trans patients with transdermal estradiol is really reassuring. And even if you look at the STRONG study, which was the big cohort from Kaiser in the US, and they found that there was a twofold increased risk of thromboembolism among all comers in the transfem arm, the number needed to harm was like 115. And that wasn't reported in the paper. So when you read that paper, they're reporting relative risks, but you have to actually think about the number needed to harm. So I think the take home for this patient is, number one, for anybody over 50, I always say, look, we should really be going for the lowest tolerated, which is kind of my approach regardless. Get rid of the testosterone, replace physiologic estradiol, and then when they get to 50, you really start thinking about lowest tolerated dose at the lowest end of the physiologic range to prevent having vasomotor symptoms, low energy, low mood, and that sort of thing. So this patient came to see me, and we kind of went through a whole rigmarole, and everything seemed to be in order. I would androgen blockade them, and then I'd put them on starting at like 50 to 100 micrograms of transdermal estradiol in a shared decision-making informed consent. Can't tell you definitively this is not going to cause you to have a clot, but probably not. And I would watch them closely and go from there.
Yeah, I agree, I think, with all of that. So all of these cases that we're going to see are my actual patients. And so one of the things that was important to me about Layla and that I really wanted to sort of affirm to her was that every provider who she had seen had said no. And that's really common, right? Like for many people, you are going to be the first person who says yes. And I think when I first started prescribing hormones, I was really nervous because I didn't have a lot of training. I started doing it during my residency. I found out about the WPATH years later, so it wasn't something where I felt like I had a lot of backup. And I feel like I now have kind of, it's like say yes to the dress, right? Like you have to be like really compelling reason for me not to give you hormones. And I am not at all compelled by anything I've read so far in this case to say that I think that the risks would outweigh the benefits. So I'm a hard yes.
What if Layla said to you, but I've heard about all these blood clots and things, and quite frankly, I'm not interested in estrogen. What else can you do for me?
Well,
what would you say to that?
I think it's really important to have conversations about their goals, particularly their aesthetic goals, right? Because it may be that we can achieve a lot of what they're wanting through non-hormonal ways. And so really having that discussion about, like, what does this look like for you? How can I be a navigator? Because I'm not the captain. You're the captain. But how can I be a navigator in this space and help you get to where you want to go? And let's walk through a list of, let's create a list of what your top priorities are and then talk about how we can have you achieve them.
Yeah, so I agree totally with that individualized approach. I think that taking a step back and thinking about this patient and the general approach. So when I first started doing this work, I kind of had contextualized or conceptualized hormone therapy, feminizing hormone therapy, as like driving a car. Testosterone blockade is the brake pedal, and estrogen is the gas pedal, and you have to have your foot off the brake and on the gas in order to move forward. But what it really turns out to be, and is that these new electric cars that have just one pedal, right? And that's just the testosterone is really, if you have a cisgender female comes to see you and says, I wish my body was more feminine, do you check her estradiol level? And if it's 70, do you put her on estrogen? No. And it doesn't matter how old that person is or what their levels are or what their goals are. So you need a little bit of estrogen in the mix before you're 50 to prevent yourself from getting osteoporosis. I think estrogen probably also makes people feel a little better. There's probably a libido component, a mood component. There's some vasomotor stuff that's very real and objectively measurable. But the primary predictor of this stuff is the presence or absence of testosterone. In general, I don't like to do the kind of like androgen blockade only in patients who are like, I'm just wanting to explore. I want to see what it feels like to not have testosterone, because I think that that's kind of like a false sale. I think that if you take somebody's testosterone away and don't replace it with anything, the patient is at risk of feeling crummy and then saying this isn't for me. So for like patients looking to kind of dip their foot in the pool, I might start them on just like a little bit of estrogen. But that's not really what this is a little bit different. But keeping that in mind, I would talk to this patient about gently lowering their T over time. If the patient is like, I don't, you know what, doc, like even if you're comfortable giving me 50 mics of estradiol, I don't want to do it. I just want to get rid of this testosterone, you know, and I'd be like, sure, you're 54. It's totally appropriate for you to kind of physiologically to us to make you agonadal. Let's do it in a measured way. So let's start you on Spiro 25 twice a day or once a day. Let's check your baseline T. Somebody who's 54 might have a baseline T that's low already. So I might, in that case, I might check the baseline T and then taper them down and see how they feel.
I think there's a lot of that coming up too. So
Great.
we can click through.
And just to put in a plug for gender expression stuff and non-medical and non-surgical intervention stuff, which unfortunately we didn't get to in the primary care talk. But there is a lot of things that people can do also to try things out, see what feels right, and also knowing that, you know, hormones take a while. Right? And the older you are, you may not have as profound effects, or people don't have access to surgeries as well. So again, some of these gender affirmation things, padding, you know, different things like that, makeup, hair, clothing, speech therapy, gait therapy, things like that. And that can also have non-binary goals as well. Can be supportive. It doesn't have to be, you know, super binary. Facial hair removal with electrolysis or laser. Like, these are all things that can also help support people as well without kind of going down that medical and surgical road as well.
So Jen, just a quick thing, because I want to, everything you guys have said is wonderful, and I just want, because Maddie is new to the room this afternoon. This morning, everything you said, plus actually even casting some doubt on how strong to even worry about first pass effect, if it's even true, and so even stronger than what you said.
Okay, great. Thank you. So let's look. Okay, so here is Layla's meds. And basically, we'll just kind of pull up some thoughts about the meds and things. Erica, you want to?
So, I mean, I don't know about you guys, but man, everyone is B12 deficient. I have not met a single person who has enough B12. I feel like it's like vitamin D, where it's like, oh, everyone's checking it. And then they're like, no, stop checking it. Everyone's vitamin D deficient, right? So anyone who's on metformin and omeprazole in my clinic is getting a B12 level, because these people are coming in with neuropathy and it's like 162, and then you put them on B12 and they think you are a god because they feel so amazing. So I would do that. And then I would probably switch to rosuvastatin because the LDL is too high and Rasuva just has less drug-drug interactions. So, but again, that's kind of more of our primary care stuff. It's not necessarily hormone related, but I feel like, you know, 90% of what I'm doing with my patients anyway is primary care. And then it's just like, oh yeah, that's right. And your hormones, and they look great. Let's refill your estrogen because it's fine.
Great, okay.
Oh, and I would decrease the ibuprofen because of the kidney function.
Okay. So,
Although their creatinine was 1.1.
Yeah, but with the hypertension and the diabetes, I'd worry about 800 TID of ibuprofen. That chronically, that's a lot of NSAID.
Yeah, I think the comment I just wanted to make, you know, not dipping into the bigger picture of NSAIDs and everything, but just remember to, when you have a trans femme person, it's best to use the male, you know, consider the male upper limits of normal for renal function, because myocyte, even though muscle volume goes down, myocyte number remains the same, so there's a little bit of extra creatinine floating around in there.
It's a really good point.
So this patient's in her early 50s. Is there an upper limit to which people feel comfortable starting hormones? For instance, I have a 74-year-old who came to me wanting to start, and we did. And it's important to her to have hormone, not to do surgeries or not. She really wants estrogen in her body. But this is the first time I've started on somebody in their 70s, so I was just curious if is there an age?
I don't have a hard age.
I don't have hard age. I just do shared decision making. You know, I mean, as people get farther from 50, I talk more and more to them about the stuff, you know, that I kind of mentioned earlier. And you know, I have a couple of patients in their late 70s with co-occurring, you know, kind of bread and butter medicine stuff, you know, diabetes, hypertension, all that. And I talk to them, and you know, I do the same kind of thing of like, look, getting rid of the T is the primary goal here. and we can replace a little bit of estrogen, but every amount that we replace could potentially confer a harm. We just don't really have great data to tell us how much, and some patients are like, I've waited 79 years,
Right.
Right, and we talk also as people are older and have had more sort of natal hormone exposure to a certain hormone, like the effects of your hormones may not be as profound as if they were like in their teens or their 20s, but the emotional benefit cannot be understated. And it is so clear, and all of you here who have started hormones on people and then had people come back, it's like, I am me now. And for a lot of our folks who have also waited for a long time, society's a bit different. Like I had one patient, they were like in their late 70s, and they came in and said, look, I've always felt this way, but the truth of the matter is I was in a marriage, I had kids, there was a lot of risk, I had a very gendered job. When I told my spouse that I was a trans woman, my spouse was like, that's fine, but as long as you never use hormones and you never have surgery, we will stay together and we will be fine. That is a commitment I made to my spouse. My spouse passed last year. And now it's my time. And I'm going to make sure that I go to my grave the way I've known I always have been. And so I think, it's really profound stories as well of why people have made decisions in their life that haven't always been what they wanted to do. I had another patient who, a trans feminine patient who was assaulted in a public restroom and felt that it is not safe to present in society as a woman. And so then chose to not present in society as what society sees a woman looks like. And they were miserable, but that was a decision they felt they had to make for safety. So again, talking to your patients, understanding why people are making the decisions they're making is really going to help you to understand and better support your patients. Okay. So what about,
Why the transdermal estradiol in this patient?
Well, again, the belief is, and I know there was a remark about, Josh said about not even knowing if there's a there, but there's some belief that, there's some data that shows that oral estradiol is more thrombogenic in any form than parenteral estradiol. It makes sense at a kind of mechanism of action basis because parenteral estradiol is getting into the blood the same way that estrogen gets into the blood and somebody's got an ovary. It oozes in through a capillary bed. So when you have bioidentical estradiol oozing into the blood in a capillary bed, then you would imagine it has the same kind of effect on the clotting axis. There's, the mechanism in the liver is there can be an imbalance of protein C and S and the production because of first-pass metabolism that occurs when you take oral estrogens. The effect size of that impact is pretty low from available data. When you have patients who have this patient is highly thrombogenic, so they're kind of at the extreme, so they may be at a steeper point of the curve for effect size. So that's why I would avoid oral estrogens in this patient.
And injectable, right?
Well, injectable estrogen, I don't like injectable estrogen for a lot of reasons. It's fussy to deal with, and, patients peak trough, and they cycle, and they have mood stuff, and they always want more because they're feeling icky the day before their shot, and there's no benefit, and then it just kind of like a community level perpetuates a perception that, like, if you take injected estrogen, it works better. But your body just cares what estrogen is in it. And the people who are saying the injections work better, their estradiol levels are probably like 1,200 and they're chemically pregnant. And if you make somebody chemically pregnant for 10 years, you'll probably make their breasts larger too. So, I think injections are fine as long as you and the patient are up for the potential fuss of dealing with it and you are monitoring your levels to make sure you're not peaking out too much. And if the patient's feeling icky before their shot, you're checking a trough and then splitting your dosing up to kind of manage it accordingly.
Great, thanks. So with this patient, we've got, our estradiol is a bit low at 34. The total testosterone is in the 300s, and she hates her patches. And doesn't matter if you have her on Climara or Vivell Dot, she hates them. And she wants shots or pills. So what are we going to do there?
I would probably, again, I think it's a sort of risk-benefit discussion, but I would probably say let's try pills for precisely the reason that Maddie said, that The injectable estradiol, what I have run into, and I do actually have a fair number of people who are on it, but what you see in the literature for the starting doses, so you'll see 20 milligrams every 2 weeks. If you want to hit the stratosphere, sure, go ahead and do that. When I put people on injectable estrogen, I start them at 1 milligram a week. So a very, very, very low dose. But the challenge with that is that you have to make sure that you have the right syringes to administer that, because the volumes are very, 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 very small. So I feel like for all the reasons that Maddie said, pills are probably just going to be an easier way to get there than the injections.
So I would actually do injections.
I love this.
This got a richness of discussion. I would do injections, and what I would do, because I agree with Erica that the syringe issue, in my country, in the US, the syringe issue is out of control. You order a 1 cc syringe and a patient sends you a message 3 weeks later, they're dosing like 5 times. The pharmacy gave me this 10 cc syringe. And these are pharmacies that if you make one little decimal thing or something on the prescription, they send you this nasty gram that you have to fix it. But they just replace syringes willy-nilly. So for somebody like this who I'd be starting, if I was going to use estradiol valerate, I'd probably start them at 2 or whatever, 3 milligrams. And I would go sub-Q. There's that non-equivalency, non-inferior study. I would go with sub-Q. It's just easier to deal with. And then I would start them at a low dose. And at about 2-month mark, I would check their peak and trough. Definitely their peak. I'd be less, I'd probably check their trough because I'm expecting they may come in and say, I feel icky before my shot. Takes 2 weeks to get an estradiol level back, so that way you have the data in front of you. So I'd try to get a peak and a trough on them, and then I would just kind of dial them in so that their levels are at the kind of low end of the physiologic range.
What about a vaginal estrogen ring, like fem ring? What are your thoughts there?
So if this patient had a vagina, I would not use any vaginal estrogen on somebody who has a penile inversion neovagina because it's skin-lined. And then if they have, there's zero data for colonic and peritoneal vaginal administration. What I think other alternatives to the patches, which are annoying, but the gel and the spray are available in some locations. Other places they're not available. And I think it's important. There might be people here who work places where patches are just not available either. So injections might be your only parenteral option on the table. But if you have access to things like gels and sprays, they don't do a great job. If you read the package inserts, that this kind of verifies it. They're not great at getting physiologic estradiol levels. Those are formulated for menopause, and no matter how much you give, you kind of hit a saturation point. But they may be perfect for a patient like this who doesn't want to deal with the patch. If you have access to a gel or a gel or a spray, it may be enough to kind of give them no vasomotor symptoms.
Okay, great.
Sorry to go back, but you mentioned measuring the peak for the estradiol injectable. When do you measure that?
So this is so important because when you get the lab back, you don't necessarily know when the person got their labs drawn. And I actually have started to have pharmacokinetic conversations with my patients so that we're all on the same page about how, if we check first thing in the morning and it's a trough and they're like, but it's not in the range. I'm like, yeah, but it's the lowest it's ever going to be because it's a trough. And then talking about, peaks and things like that. So for estrogen and testosterone, I tend to get mid-cycle values, primarily because I think in my population where people are having to come a really long way to see me, because I see people in a geographic area the size of France, that I will say, well, we're just going to get the one test because I don't know that it makes sense for us to do it twice. So I will usually get both injectable testosterone and estradiol on day 3. So if they inject on Monday, they would get the lab drawn on Thursday.
So I do peak and trough. I educate my patients on what that means. As part of starting injections means they have to understand how it works. I have some educational materials that's given to them as well. We also have an injection handout. So our approach to training patients on injections, we have an injection handout that we give them that has a picture of both a 1 and 3 cc syringe on it. We circle where they should draw for both of those so that they do have the pharmacy switcheroo on the syringes. We still have some coverage there. all patients who self-inject, regardless of if their friend's a nurse, their brother's friend knows somebody whose cat has diabetes, they all have to get they all have to get trained in injections by they either have to do, we have a set of videos that actually not made by us but by a couple of other clinics, and they have to watch those videos, or they need to come in and meet with our nurse, or they can do a nurse telemedicine teaching. Kind of patient by patient we figure out what's needed. So we make sure they know how, kind of how to measure it out. But then I do feel strongly about checking the peak, especially in a patient like this. And I think it's, we also, I see patients statewide. California is, I don't know how it's, I think it's probably the size of France. And then I also see patients from Oregon where I'm licensed. And so a pretty large catchment area. There's a national network in the U.S. of a couple of different commercial labs, LabCorp and Quest. And so patients can go in their own hometown. And then for patients who live in very rural areas where there's only like one local hospital and it's not on that network, we actually have our staff reach out to the patient and figure out where they're going to do it. And the patient then tells us when it's done. Our staff then contacts that hospital, gets the results faxed. So we don't. So patients do labs, kind of wherever they are. That's my approach.
So what day after injection do you get the peak? And
I do. I have them do the trough like right before their shot, as much as possible, and I have them do the peak the day after. If they inject on a Saturday, labs are closed Sunday, so I have them go Monday, and I try to kind of backdate it a little bit.
How do you deal with patients who, well, since you put me on shots, I've had amazing breast growth, I'm curvy, I feel incredible, and my E level is 1200, and if you lower me, I'm going to reverse and I'm going to feel terrible. And I read on the internet that you WPATH people, like, your levels are way too low.
Wow. Okay. So I want to. I want to give others a chance to respond to this too. But so the first one is, I say this with a great degree of humility, but in general, my estrogen injection patients that I'm the one who's starting them, they don't get to 1200. I have patients that probably the most I overshoot is usually about 500 or 600 based on my starting dose that I use, and those are patients who I've kind of prepared for this, and then I pull them back, and that's part of the agreement that we make when we start injected estrogen, is that the management of injected estrogen involves, like, part of it involves having physiologic levels. The second thing is that if I have a patient who comes to see me and they're on some very high dose and their levels are really high, then I work them down. But I will tell you, I'm trans myself, and I do this work because I feel strongly about, providing medical care to communities in need. But I also feel strongly that my community deserves quality care, and I challenge everyone to think about patients who have other needs who would be demanding things. I heard metformin makes you look young. I want to take 1,000 milligrams twice a day, even though I don't have diabetes. Like, would you prescribe that for the patient? Probably not. So you have to kind of, this is like, a patient wants amoxicillin for a cold. You have to talk them down. And so, of course, harm reduction plays some role, but I think that for some reason in the trans medicine field, there's like this, I don't want to put too many barriers, and so, but it's okay to put your foot down. So we do put our foot down with patients, and we say we're not prescribing injected estrogen for you anymore because we have not been able to effectively manage it. You have not been reducing your dose. You're not getting your blood tests done. We're concerned about other health. And eventually, we do kind of pull them back. As far as I read it on the internet, the other day a patient wanted me to do something that I forget what it was, but they were have read studies. I said, oh yeah, what studies were those? Well, I don't remember what studies. And then finally it was my friends told me. So there is a subreddit out there of things Maddie Deutsch won't prescribe. And I found out about this. And I'm okay with it, I mean, so I that's kind of how I respond to that.
And I actually will say, well, no, I'm not going to give this to you because Maddie Deutsch doesn't do it. So if she doesn't do it, I'm not going to do it either.
I think another really good argument, especially for all the power stuff, is just, if you had diabetes, I would use evidence-based guidelines, right? I wouldn't just tell you, go look it up on the internet and then do whatever that says, right? And there is, why is it okay to have experimentation in a gender diverse community when we would never allow it in other communities? And, at the end of the day, maybe there are providers out there who are not sharing their research or participating with the evidence-based folks who are designing guidelines. But, and maybe at the end of the day, like years from now, it'll be like, hey, they had it right, or hey, they had it wrong. But the truth is, it is experimentation, and we just have to call it for that with our patients. And when I talk to patients about that, there's this like, oh yeah, that's not okay. Like that's not cool, and I get it now.
I try to hit 100 to 200 picograms per ml.
Yeah, I mean, if you look at the different ranges, you've got the range that your lab reports. Your lab may give you, follicular cycle, mid-cycle peak, and then luteal phase, and so, it's a very, very wide range, and it probably doesn't matter where you are in that range. I tend to err towards 1 to 200. With the injections, it's a little harder to hit the nail on the head, so I tend to be okay into the mid 300s if the patient's feeling okay for a young, healthy patient. If this patient was going on injections, then I would keep them below 200 at their peak. Yeah.
And I think the other point that this case is trying to make, and I'm glad you're speeding up because we're like never going to get to the other cases, but what can oftentimes happen, so this person is on a fairly hefty antihypertensive regimen, right? And so, and again, these are all real people. And so, she was coming back and she's like, oh, I feel lightheaded. I kind of feel foggy. And then I was thinking, oh no, this is the Spiro foggy thing. No, she was hypotensive because we had her on a fair bit of spironolactone. So what we ended up doing is, okay, like we do for all blood pressure, right? Here's a blood pressure cuff. Go home, measure what your blood pressures are, send them to me through the MyChart, and then we're going to have to, I think, start pulling back on some of these other things because you don't need this much antihypertensive because the spironolactone is actually a fairly decent antihypertensive. So at least in some circumstances.
Right. And then what would be your thoughts if she's like, I just cannot tolerate this Spiro, I'm peeing too much, I'm feeling faint, whatever. What if she didn't want to take the Spiro or no matter what, you couldn't just get to a good place with the Spiro? What would be some other options that you would offer for her?
So I know you have some experience with GnRH. I haven't been able to get them covered, and I don't know if that's like a Utah thing or something else. But I would probably say, let's have a conversation about whether or not an orchiectomy would be a good idea. In this case, she's very eager to do vaginoplasty, and so it was like, well, let's do that first because we'll kind of take care of that en route to the vaginoplasty. But I know you've been able to do GnRH, so I'm curious what your thoughts are.
Yeah, I mean, I'm privileged to live in California, where there's a great deal of policy in place, and getting GnRH analogs is often just a few minutes of work by my medical assistant to do the prior auth. So there are some places where it may not even be available in country. So I think we should recognize that. The GnRH analogs work great. There are something that I think is totally unstudied and not really an area for experimentation on patients, but something to look at is there are these new GnRH direct antagonists that don't have the problems of the earlier generation of anaphylaxis, and they're oral. They're a little cheaper, and so I'm hoping that might be an option down the line. Orchiectomy. And generally, I don't like to have patients go right for orchiectomy without prior androgen blockade because it can make them feel really crummy to have that kind of sudden plummeting. But this patient, there may not be many other options. I'm not a big fan of the utamides. They're not. They're not. You can't really monitor like effectiveness because they don't really lower your T level, so you can't really monitor. Somebody's T level when you're taking one of those. So, this patient, there might be some room for adjusting their hypertensive regimen because it's not the Spiro brain fog thing. It sounds like they're over-medicated. I mean, the only thing I would say about that is, we've learned a lot about managing hypertension in the last 15 years, and that there are some medications that are great at getting your blood pressure down but don't have the impact on health outcomes that you're looking for. And Spiro is not one of those antihypertensives that affects health outcomes of interest. So I think it would be important, to kind of discuss with if there's a specialist involved, a cardiologist or nephrologist in the mix, you might want to kind of check with them too about it.
Great, thanks. And just to finish up with this case before we go to our next one, same thing with transmasculine people. Hormones can be lifelong. They don't have to be if your patient's like, hey, I've been on this forever and I want to take a break and see what that would look like. But they absolutely can be lifelong.
Yeah, there was a window of time where I think sublingual was the kind of treatment du jour. The theoretical was that because it gets absorbed, via the oral mucosa, it's then not parenterally absorbed. I think that probably is not like super true. I do have patients who come to see me who've been on sublingual estradiol. I tend to see them; their levels are all over the place, and it depends on where in the day you measure them. And I think that because their levels are all over the place, those patients tend to have a harder time getting their T levels down too, because estradiol does play some role in suppression. And the one study that was done shows that there's a very strong peak trough effect. So I steer my patients away from doing it because I don't really think that there's much of a benefit there, and I think it's fussy to deal with.
Yeah, and they're, the pills often aren't formulated for sublingual, so they'll be like sucking on that pill for hours, like it's a lollipop. So it's just like, no, just swallow it, It,
Patient who tried to do sublingual Spiro, and they were like,
right.
I'm gonna throw up from
it's
this.
still in my mouth from when I took it, Yeah, don't do that.
So we want to respect that our surgeon is coming back soon, but we certainly can also do more cases after that if our folks want to stay or cannot stay. But we can take a few more questions until our surgeon comes back, or we can do some comments.
Yeah, I have a riveting work administration meeting I have to go to eventually, but I can stay for later.
Maybe let's skip to the I think it's NEO, the NEO case, because that I think is something that we're all coming up with.
Yeah.
And like you said, you guys will have this, and maybe we could even have like Josh or Maddie or other people maybe write some comments about these questions, because the slides themselves don't actually have any of the answers. It was all meant to be kind of discussion based. But
fantastic. Yeah. So we're just going to go ahead and get started with this, because this is a 23-year-old non-binary person assigned male at birth, they them pronouns, comes in, wants to establish gender affirming hormones, and of course read a regimen online: estradiol, progesterone, finasteride, raloxifene, which is our SERM, gender incongruent since puberty, socially transitioned in their teens. They want an androgynous appearance. They want less facial and body hair, vocal changes, voice is deep, but wants it to be less obviously masculine, and does not want breast development. So
yeah,
what are your thoughts there?
This is becoming a very common thing. I think this has grown legs on Reddit and Discord, and I think the word is out now that I don't think it's a true word, but it's a word out that if you take a SERM and you take anti-androgens and maybe also take estrogen, maybe via 2 different routes, then somehow this magical cocktail gives you a body that is feminized with no breasts and basically like non-virilized, like neutral body configuration. And it sounds like a good idea, and it sounds like it should maybe work, but it just doesn't. And I don't really know. I memean, the SERMs are not like 100% blockers. There's other stuff going on. And SERMs are associated with blood clot risk. So I let patients try this. I have some patients on raloxifene because I do the shared decision making. Probably doesn't work. This is one of the few things that I have like kind of let happen, because I'm like, all right, well, it's probably not, as long as we kind of talk about the potential clot risk, and these are young, healthy people, but it just doesn't work, and I just say, like, look, if you really want to have this outcome, then you should go for top surgery. But I will say this, and I think it is important to put our thinking hats on. I have had a number of these patients who try it and then they get breast development and then they say, oh, heck, let's just go for it and I want maximum effects now. I think it's very important when you are doing hormone therapy and you kind of are the only person in that patient's care package that we think about the kind of psychosocial support that patients need. There's internalized transphobia is a real thing. Patients do not give themselves a permission to pursue what they want. Another real thing are people who want non-maximal changes to their body. Both are very real. The real trick is sorting out who are who and helping patients get to that decision and not making patients feel like you're stroking your chin at them out of curio, or that they're being otherwise kind of unpacked in the 17 minutes or whatever that you have to see this patient every 3 months as a non-mental health trained physician or medical provider. So, you know, that's probably like a 4-hour symposium right there, but just something to think about.
Yeah, and I would say this is why I love coming to meetings like this, because I think that, you know, 5 years ago, I never would have considered, you know, this regimen because it just would be completely outside of my wheelhouse. But I think there is a lot of sort of practice variation across the, you know, the world. And so it's really good to hear sort of what other people are doing and trying and success and not success. And so, again, I feel like I want to be the person who says yes to the dress, you know, and I want to be the place where they can come and we can have, you know, conversations. But I think I would try and have it be kind of more of a negotiation, because like with COVID and everything, when people were asking me for hydroxychloroquine, I mean, that wasn't something they could talk me into, right? Like, so I think it's about a dialogue.
Great, thanks. And Alex is back, so we're gonna turn over the rest to Alex, and then we can always come back for cases too.
I just want to say one thing before we go to Alice. You want to?
Sorry, no, it wasn't a question. It was just as a mental health therapist, what I have been getting from a lot of my clients is there's a fear that if you're not certain about what they want, you're not going to get treatment. And so, I mean, just to be able to reassure clients that they don't have to know all the answers about what they want, be able to talk to about how they feel, and it be a process that they go through with you. I think that, I mean,
That is such a great point. I had a patient sort of self-refer to me because the endocrinologist they were working with, they wanted to be on a feminizing regimen, but they wanted to have erections and enjoy their body parts with their partner. And the endocrinologist was like, well, if you want to have penile erections, then you're clearly not trans. You don't know who you are. So, yeah. So, again, we need to kind of embrace that individual goals, what is realistic, what isn't, what's reversible, what's not reversible, and just kind of have those realistic conversations with our patients.
So I just want to say one global point with regards to the cases. You can see we can go on and on and on. I want to thank everybody for your interactions because I think we learned as much from each other as from this local panel. You got two different panels, two different things, which is kind of interesting. Half a dozen of us. And you will get all of the slides, including all of the cases. And I think as you go through some of the cases, you'll see that we actually discuss the key points of other cases in the wrong case. And you'll be like, oh, yeah, and then fine. But if that's not really the case, then, you know, you could go ahead and reach out to all, I think I can speak for all of us, but I can for sure speak for me with continued email conversation with space. That's, you know, that this is, the idea is to get educated here and not to all do it in the few hours we have to do.
And I can affirm that that's true because I've been emailing Josh for years.
Yeah. So I'd like to thank Dr. Deutsch for her contribution today. She's going to a work meeting now. Thank you, Maddie. And then maybe to save time, if Erica and Josh and Michael and Janet, when Jenna comes back, to come sit up here, because Alex is going to finish before time because he's going to the surgeon's dinner, and he's arranging that, and so I would ask him now if he could please come and finish his talk, answer some questions, and I'm going to ask the rest of the panel to come up so we can also have a Q&A. So thank you.
All right. So yeah, I apologize for this. You know, there's a lot of running between rooms, and we're hosting, and so everybody's asking a bunch of organization stuff. I'm trying to do my best. So let's go over the masculinization surgeries now, and I'll go over mostly mastectomies here, and then we'll talk about phalloplasty, metaidoplasty, because I think that's the most two important surgeries. So, what technique? Mostly, when we talk about mastectomy and top surgery, we want to assess the skin laxity, skin elasticity, the volume of the breast tissue that we have to deal with, and in patient considerations such as do you want to keep your nipples? For example, we have more and more patients who don't want to have their nipples. They're going to do tattooing, or they're not going to do anything at all. They just want a little bit of a flat chest, sometimes keeping a little bit of a mound on the chest. So there's degrees, various degrees of asking there. Have they been binding? For how long they've been binding? Binding is definitely a life-saving measure for a lot of teens, but it does also stretch, the skin, and that's okay. We'll deal with that, but it's something to understand. That means that some techniques maybe will not be able to be used on those individuals because they were binding, and that's okay too. So that's what you would be looking at. So periareolar and double incision, kind of the big two things, either a very small incision, getting rid of the volume of the breast underneath the skin, keeping the skin intact, so you can hide more. Nobody really knows you had surgery. In some cases, you can retain some sensation, although that's controversial because most of the nerves are actually cut. Or a double incision because you have too much skin laxity, not enough elasticity. It's not going to recoil after your surgery, so you're going to keep that sort of empty pocket of skin if you don't address that and remove that skin at the same time. So look at two, individuals. The volume is, so we could almost say, pretty similar, but it's a little bit more. It's more lax on the left side. The patient is a little bit older. Elasticity is less. Binding has been more done throughout the years, whereas you have a young patient, I think 19 on the right side, you can tell that the skin is elastic. If you pinch on it, it's just going to recoil and retract very easily. So that's a very good on the right side candidate for a periareolar mastectomy, whereas on the left side, that skin is never going to go away if we don't address it right away. The nipples are not going to come back up on their own if we don't place them back up under the form of a nipple areola graft. And so would prefer then a double incision mastectomy in that case. Is there an objective measure to do that, all the elasticity and things that I was mentioning? Well, there's been some gradations. Looking at laxity and positioning of the neck above or below the IMF, and what you have to retain here is that the threshold is really 2B. When you have a 2B patient, then you're going to go more towards the double incision. Anything below that 2B, so 1 and 2A, can have a periareolar if this is what they wish. It's very important to, of course, everybody would want to have the most minimal surgery as possible, right? The very small incision, and so nobody sees it, you can hide it. But you have to counsel patients well, because if you're doing the wrong surgery on the wrong candidate, then they'll have to live with the consequences of keeping that skin. It's very hard to correct. Sometimes it's not even, depending on, for us, province to province, it's not going to get funded. It's going to be considered cosmetic, which is outrageous, but, it is something that they could be dealing with. And so this is one of those patients who was operated somewhere else with a periareolar mastectomy, and you can definitely tell what I was mentioning, that sort of flat tire look on the left side. Of course, the patient's not happy with that and was seeking revision. Very interestingly, though, 5 years after the initial mastectomy, which is quite a long time living, with the extra skin, and we did so here converted to a double incision mastectomy with then nipple grafts to replace and put them in the right position. This was just a very early post-op. This is why it was that way. So this is just the markings. Maybe I can skip that and I'll show you just the dissection. If you guys are okay with that, if you're not, just turn your head. So you have to find the right plane. You have skin and then fat underneath there, and then you have breast tissue. So you want to find the limit between not leaving breast tissue, but keeping a good thickness of the skin, so the skin's going to survive. It needs to have all this blood plexuses. You're going to go down to the pec muscle, and you want to really get all of that tissue, because otherwise it's not going to be perfectly flat everywhere, and you can have like little bulges here and there, and this is not good. So you want to make sure that the flap is really nice and uniform everywhere. And then you're going to get that gland off the pec muscle like this. So once you have done that, then you're going to assess for the tension before you do your inferior incision, so you can close in one single line without leaving too much tissue, but also without leaving too much tension on the skin, because otherwise that scar is going to spread, and you probably have seen some of those results where the scar is super wide, and it's probably because there was too much tension on the closure. So leaves a huge gap, right? I mean, when you look at that, it's pretty invasive surgery, but we can close it pretty well in 3 layers. It heals well, but the key here again is to make sure that you have a deep closure so that the tension is not on the skin. If the tension is underneath the skin and at the skin level, it's not going to spread open, it's not going to widen. So you're going to keep all those long-lasting stitches, 180 days stitches there in the deep layers to make sure that, that you have a strong closure. This particular patient didn't want nipple grafts. Complications, bleeding again. You know, sometimes those little arteries retract during general anesthetic. You have hypotension as well, so it doesn't bleed right away. Patient wakes up from surgery, a little bit agitated, pressure goes up, boom, here goes your little bleeder who's going to start, and then you have a hematoma. I take the patient back for drainage. Few days/weeks later, you can have production of fluid inside the pocket, so you have this big a pocket of fluid. That's a seroma. You want to drain that. You can mitigate that somewhat with drain placement and leaving the drains as long as needed, but then you have to make sure that there's not going to be an infection, because anything that goes in the wound gets everything out of the wound, but potentially gets the bugs in the wound as well. So it's a fine balance here. The grafts could have issues. It's pretty rare, honestly, to when the nipple grafts being like completely lost. What you're seeing mostly is little scabs that end up falling, but the nipple is underneath there and is well viable. Loss of sensation. It's not so much of a complication. This is an expectation of this type of surgery. So that's very important also to counsel. If nipple sensation is very important pre-op, we have to rediscuss the goals of the surgery. We have to maybe guide towards maybe a volume reduction, breast reduction, instead of a mastectomy. This is an example of a hematoma. You see on the left chest here how big it is, and this was just a couple hours after surgery. The patient was still in-house, so you can take them back to the operating room very easily, and then you drain that hematoma. And that's 1 month post-op. So no implication on the result, but you got to identify and take care of it right away. Partial nipple loss, the perioral mastectomy on the left side, you see here. So wound dressings healed pretty nicely, but we lost part of the areola, which was already smaller, but the patient didn't like that, came back to have it removed completely, so that's what we did. And then expectations. So we do operate on higher BMI individuals. That's not an issue. But we have to counsel and say, you know, this is where the footprint of the breast is. This is where we can address some of the lateral rolls. But there's also a little bit of tissue coming from the back, and I'll reach as back as possible, but I cannot remove everything, because that would be, you know, turning you prone on the operative table, and that would be more considered cosmetic when we talk about who the third payer who doesn't want to cover those part of the surgery. So we need to make sure that the patients understand that very well as well, so that they're not upset after surgery, because if they want a revision, it's unlikely to get covered. And then we're seeing more of requests that used to be called non-standard. I think it's just like the customized surgeries I was mentioning earlier. And it could be placement of scar being more curved or straight. It could be the nipple areola complex being a little bit bigger or smaller, placed differently, more external, more medial, for example, or leaving some various degrees of breast tissue behind just to leave a little bit of a mound, in which case you have to counsel for a breast cancer screening also after. And then potential, you know, add-ons to that surgery like liposuction. And that's just a few results to show you double incisions. Different body types as well, that's important to show. And then without nipples. Okay, so outpatient surgery, compressive bandage, super important with the drains, because you want to make sure it's a pretty wide dead space. You saw it, right? It's a big hole here. So that's going to be empty. nature wants that to fill it with fluid, so you want to apply some compression so that the tissues stick back together. So that's super important. That's the reason why either a chest binder or an ACE wrap. Most patients here don't want to pay for a new chest binder because they're going to use it for only 1 month and then they're done. So they'd rather use the ACE bandage. But that's okay, and that's to their preference. It's normal to have a little bit of tingles. The nerves are going to regrow and give some sensation back. So you can have some weird feelings at first, and this can last for quite some time, actually. This is more done so by the OB surgeon, hysterectomy, salpingo-oophorectomy, but typically I think it could be an overnight surgery. It's done through laparoscopic small incisions now. And you have to, outpatient now even better. Yeah? Do you guys use Exparel too? Exparel? No. Not that painful. Good. Yeah.
Two questions. One, do you have a weight that you will not do a mastectomy or a BMI that you won't?
We try to place it around 40, but I've had individuals that are way above that. I think if they tell me this is the body I'm good in my body. I don't plan on losing weight. I'm totally fine that way. So either I have the mastectomy or I don't, but it's not going to change because this is who I am. I'm going to operate on them, right? Because that's their choice of their body. But if they say, well, you know what? Yeah, I can walk the extra mile, definitely. Then we'll make a plan together so they can lose the weight before, so I can address a little bit of that skin laxity and take it out at the same time.
I have a GYN surgeon who's done some hysterectomies for several of our patients, and recently denied one because said I've never done a hysterectomy on someone who has not first had a mastectomy.
That's wrong. That's totally wrong. Yeah. Yeah, I mean, I don't understand. Yeah, me too. Yeah. So bottom surgery for phalloplasty, we try to go around 35. We kind of see that we have abdominal pannus that limits the access and maybe compression of the pedicle because we have to do microanastomosis there. It could be a little tough. So it's to limit the complications. For vaginoplasty, we're around 40. It makes, dissection a little bit tougher. But again, we just had this conversation in the surgeon course, and there was a team in England who was requiring 30 of BMI. So we're like, well, we won't operate on anybody. And it's, and it's very hard also to send your patients back saying, well, you got to hit the gym and lose weight. That's not how it works because you're not socialized because you feel bad about yourself and now you're getting shamed. And, we have to work with them to get them to the surgery as well. Understanding, though, that we know complications that can be at a higher rate, for example, for vaginoplasty, but not the major complications such as fistula. I think this is, in our hands at least, it doesn't change anything. But you're going to have more wound healing delays, minor necrosis, dehiscences that will require more dressing changes, and it may be longer time of healing for sure. Yeah. Yep.
What's the reasoning behind nothing above 90 degrees after vasectomy?
Yeah. So if you look at that gap, we're trying to bring everything together. Can if you picture it's here because we do the same for tummy tucks, right? Now I'm trying to leave a little bit of tension here so it's nice and flat. If I stand up straight like this, it's going to take things apart. It's going to pull on it. That pull is not going to be good. It's going to stretch that skin out. So that's when you're going to see more of that scar. It's going to get more visible. So it's just to try and avoid that as much as possible. But I've seen crazy things there. I've seen people saying, well, don't do that for 6 months. But you're going to get a frozen shoulder, right? By not doing this. So I think you have to be reasonable. We say about 1 month, 4 to 6 weeks. Yep.
I have a question. This is on vaginoplasty, but would apply to phalloplasty as well. I had a patient who was denied bottom surgery by surgeons because wasn't living full time for a year in their gender identity, but wasn't living full time for a year in their gender identity because they didn't feel safe, right, to be out everywhere. Is that in the new guidelines that you have to be living for a year in your gender identity?
you know, again, guidelines are made to give some directions, right? To help. It's sort of a GPS. If you're lost, you put your destination and it just gets you back on the way. But so for me, it's not a firm. This is not a firm guideline, for example. And I totally understand that if you don't feel, for so many reasons, safe around. But what I would have is the conversation. What would you make you feel safer after surgery? Can we work together towards you being okay after surgery? Because I don't want you to be secluded at home and not going out. And now you just had surgery. You're going to live pain. You're going to be alone. You're not going to go back to work. And maybe depression's going to hit as well because we haven't tackled that problem. Yep. I haven't yet. Yeah. Has anyone? No. Sorry. Yeah. Should we move to the genital part? Okay. So, metiadoplasty versus phalloplasty. What you just need to know on that is that metiadoplasty, it's a tough name just to say that we're going to use your tissues to lengthen what you have and not bring any additional tissue to the region. It does rely on the clitoris being enlarged with testosterone to have a better outcome, and it does allow for standing urination. Not really for sexual intercourse, although some patients have mentioned that they were able to do so. But we can't just say that it's going to work because it doesn't work for 100 people, for 100% people. The phalloplasty on the other end means that you're going to bring additional tissue from different localizations to create a phallus. So you have to take into consideration what the individual wants. I always ask the same questions. What are the goals? And most patients will say, I want to feel as a whole in my body. But then when it comes to sexual function or urinary function, the response does vary. And it's not as important to pee standing for some patients. And it's very important for other patients. Or others say, well, I actually don't feel like I will need to achieve penetration someday, so maybe implants are not going to be for me, but I do want to have a phalloplasty, so I'll never put the inflatable penile implant because I don't need that. That's okay. So we'll make that pathway together, and then we'll talk about the different steps that apply to that specific individual. A full, complete phalloplasty does involve all the blue dots that you see on the right side here. So getting rid of the vaginal mucosa, closing the vaginal cavity. Then you have to lengthen the urethra with labia minora up to a certain level at the skin. That's going to be just going out at the skin. So you'll be peeing sitting, but at a higher level. And then you will bury the clitoris that you will put underneath your phalloplasty so you can keep that sensation. And one of those nerves, so you'll disconnect one of the nerves going to the clitoris. There's actually a lot of them, a lot of nerve bundles, so we can connect one of the nerves used for phalloplasty to one of the clitoral nerves so that there could be erogenous sensation on the phalloplasty flap as well. And then you do the glandsplasty and the shaft, depending on where you're taking it from, the thigh usually, or the forearm most commonly. So when, if at all, you guys, I don't know if you know Buck Angel, but he's doing a lot of education and activist, and he's explaining why he actually chooses not to have phalloplasty. He's actually doing porn as well, and he doesn't need to have a phalloplasty. And he says he's actually, for two reasons. First, he's very happy that way, but also because the complication rates are very too much important, and it is true. That's the take-home message. We're definitely nowhere near perfect when it comes to phalloplasty. So if there's a phalloplasty. It usually comes after a bunch of other surgeries because definitely I think, mastectomies are the first thing because it's more visible. The kids have issues, going to school, and so they want to have the mastectomy as soon as possible so they can be out and about with their friends. Ideally, it would be one procedure. It would be working. You'd be peeing, standing. You wouldn't have any issues, and it'd be looking great. But it's not that way, unfortunately. So there are standards, as this very scientific literature calls men's health. You can say. This is my kind of references. Anyway, so as to what is pleasing, what is not pleasing. But patients will come and ask you for specific types of glands or size or things like that, and so you have to be able to tackle that as well. Metaidoplasty, so you rearrange your tissues. Why can we do that? It's the same embryology, so you're just working with the same tissues essentially. You will release the clitoris attachments to lengthen it, and then you will use the labia minora to lengthen the urethra. So you make it a flap here, like a big rectangle, and you're going to wrap that around a Foley catheter so that now you could be peeing from the tip of the clitoris. And that's the lengthening, and then you have the skin around. And those two flaps on the side, that's to actually bring down to be able to accommodate for the testicle implants. This is kind of, an expected result of a metaidoplasty. So the pros is one-time surgery, it works, but it's mostly, the cons is that it's small. It doesn't allow for penetrative intercourse in most cases. Phalloplasty, so here we're going to try to make it simple. What you need is urinary function and the shaft and the glands and all the cosmetic aspects, and being able to afterwards place an implant. So the best for that is to create a tube for the urine, for the urethra, and that tube to be wrapped itself in another tube. And the best, if you look at your own bodies, here it's the thinnest you can have, and maybe the dorsum of the foot, but that's too small, so we're going to be using the forearm in most cases. It stays the gold standard today to use the forearm. What is a flap as opposed to a skin graft? A flap means that you're borrowing tissue on your body but attached to a vascular pedicle, artery, vein, and here nerves. So this is why we'll divide the radial artery and the veins and we'll reconnect them in the groin. A graft is just shaving off of the very superficial layers of the skin that you can tack to a wound bed, but has secondary contraction and also has to be limited in size. So you would never be able to do a penile graft. It has to be vascularized to live well. And as plastic surgeons, we take flaps from all over the body for many different reasons. It could be after cancer resection. It could be for sarcomas, breast reconstruction, whatnot. And in this case, for gender affirmation. So the gold standard is this, the tube in a tube taken on the forearm. If you see patients that come back from their first appointment with a surgeon having to go through more testing, arteriography, for example, it's because we're going to take the entire radial artery, so we need to make sure that the ulnar left behind is going to be enough to give a good blood flow to the hand. So that's the Allen test. That's sometimes clinically not relevant. So we have to send them to the radiologist so we can inject contrast in there to make sure that it's going to be safe to do. We use a pattern here that you can see. You can see the mark. So the length is actually limited by the individual's anatomy. So we can only accommodate that much length, and we have to tell that to the patients, And so we create this. So at the stage one, we do the vaginectomy. We lengthen the urethra. We take the flap. We make it into a penis, and then we create the scrotum. Okay. Then we do the anastomosis, so it's micro anastomosis, which means it's very, very tiny vessels in the groin. We connect so that this now piece of tissue is going to be living off of the groin instead of living on the arm. And then this is what it looks like. So you have also nerve connections, so it could be sensate. It will take a while, 1 millimeter a day to regrow, so it will take a while before it gets to the sensation. And the older an individual, the less the recovery of sensation is expected. This is what it looks like. So at when we're ready for stage 2. Stage 2 means now you have the urethra of the flap that's right here. Okay. And then this is the urethra of the lengthening with the labias. So we'll just have to connect those two. The reason why we don't do it right away, it's a lot to ask here. There's a lot of swelling, there's a lot of potentially small areas of necrosis. We have to let everything settle to make sure that we put that urinary tract in the best possible condition so we don't have an issue afterwards. It doesn't close up, it isn't stricter, it doesn't cause a fistula. So you see those, the blue again and the red, so we'll connect those two together. Before we do that, we got to make sure again that there's no hair at all. So the patients are going to be sent back to the laser therapist to make sure there's no hair around that skin around, because we'll use the skin to wrap, because you'll have, you insert the catheter here, it goes out here, now you're out, you're seeing the catheter goes back into the bladder here. So you're seeing the Foley catheter here. So the second stage constitutes what? We have to elevate skin from surrounding here and then fold it on top of that catheter to make everything inside. So if you have hair around there, the hair is going to grow into the lumen, and that's going to be an issue. And that's the end. You see the closure at the end, you'll have just one line. And then finally, you'll be able to place an erectile implant. There's different types, and so with a testicle implant at the same time. Mostly semi-malleable rods, so you can just bend up or down, or a more complex system where you have to pump saline from one reservoir that actually goes into the cylinders, and then a release button that chases the fluid back out and then gives the flaccid position back. And this is the placement of such an implant. They're, again, nowhere near perfect. They tend to slide back sometimes. The pump can be a little bit hard to get, so patients need to train on how to use that pump. But they get there, and it works. So that's the question, mostly is semi-malleable versus thing. And then ZSI, that's a European company that made that implant specifically for transplants. Yeah. So it doesn't get as thick, but there definitely is a capsule. When we go back for repositioning, for example, we do go through that capsule. But in that case, if you're in a perfect spot, it's great because it's going to define your pocket. So if you have an implant exchange after, you just got to slide back in that nice shiny layer because everything is pre-dissected. So it could be a good thing in that case, yeah. This implant was created for our trans male patients, but again, the fixation it has on the pubic bone has been an issue a little bit. It's not approved in Canada. It's like a specific request. So I haven't had a lot of experience with that. But they're changing it, and people are improving it, so hopefully we'll be able to use it. Big downside of the technique that I just showed you, of course, is the donor site morbidity. And as more and more and more awareness about the type of surgery that we're doing, patients don't want to have that type of scar. You're ordering a beer at the bar, and then people are like, oh, that's a giveaway. Maybe this patient had this guy had a phalloplasty, and they don't want that. But the problem is that we don't have a lot of good additional options, and so tattooing might be a good covering for that. You could be taking it from the thigh. It has to be very good candidates, thin individuals, because you won't be able to do the tube in a tube if you have too much fat on the thigh. So it does eliminate quite a few candidates here in our societies here. Asian populations have more studies on those flaps because they tend to be a little bit thinner. And then this is just to mention it, but there's a European team that does take it from the back. And historically, we were also taking a bone from the leg, the fibula. So we were taking the bone and a skin island to wrap it. And so it was a semi-rigid state all the time because you'd have a piece of bone, literally. But you can imagine it's not very convenient. So...
What about one of my patients just contacted me where there's a single scar on the leg. And
yeah.
I'm not even really sure how the surgery is done.
So, On the leg, it's the ALT, so that's the thigh. So if you have enough skin laxity, or if you pre-expand the skin before, you'd be able to close it primarily after you harvested the flap. Or you take a smaller one and you combine it to another flap that you could take usually from the groin, and you do those two together. And one of the advantage of taking from the thigh or the groin is that, remember the concept of flap? There's pedicle flap or free flap. A free flap means that you divide the vessels and you're going to rehook them with microsurgical techniques. A pedicle flap means that you stay attached to a vascular leash, and now you can rotate around at certain degrees, right? So if you're coming from the distal thigh, you can come back up here, avoiding having to do the microsurgical techniques and potentially the blood perfusion issues afterwards. And some, so that's a good thing. Yeah. Sensation might be a little bit less, although it's pretty good because there's a sensate nerve here. This is a summary. You'll have that in your slides, but a summary of the different techniques and why to this day radial forearm flap is still probably the gold standard.
Quick question on that one, because I think we're going to be confronted heavily on the medicine side of things with giving our patients guidance in this space, especially because many of the good surgical teams do one but not another.
Yeah.
And then it's like, oh, go, and so then they're actually, the patients are looking for a little guidance from the medicine person first before they even go to the surgeon, because that influences which surgeon they go to.
Yeah. But you mean what should you be looking for?
In terms of among these, helping patients negotiate that, or is there a plan maybe to create some more comprehensive materials that we'll be able to use?
Yeah, that would be maybe we can work on some booklet like that. But I would say that look at the overall body habitus and look at the thickness of the thigh, because you could probably exclude yourself an option or just guide and say, I don't think that would be a good option for you because I don't see how you're going to shape this. It's not going to be a cosmetically pleasing also a phallus there, and then you can sort of guide. But I believe that teams should be doing more and more and offering different options as well, hopefully.
So this is a general question. I'm a nurse practitioner in primary care, and I'm new to the WPATH community. Is there a resource that, all of this is extremely specialized with a lot of risks and then a lot of failure rates. Like, is there a place where people are getting their resources on surgeons and teams who are doing this?
Well, and probably, members of the community could be talking. There's fellow.net, I think, which is a good source of information online. I don't know if anybody can comment on other additional resources.
There's tons of forums out there talking about surgeons, and there's mft.net and ftm.net that talks about all of that stuff.
Do you want to talk in?
There you go. So there's a lot of forums out there talking about exactly that and which surgeons do what. And I actually have a website that I do because I'm a mental health gender specialist. And so what I've done is if you go to mft.net or ftm.net, I believe it's .net, it might be .org, but they have a lot of information in regards to surgery terms, surgery teams. But if you go to livinggenderdiverse.com and go to my resource page, you can look under there for surgeons and getting like grading cards and getting input and stuff like that.
That's awesome. Okay.
For all the surgeries you're talking about, nicotine use.
Yeah.
And any of these okay for smokers?
No. I mean, so between pot and nicotine, I'd rather them keep the weed, but edibles are probably better because if you smoke a joint, some people put tobacco in there. I'm not going to go into the recipe of a joint, but the nicotine does shrink the microperfusion. That's the problem. So it does impair the wound healing, and it could be for a mastectomy, it could be for a nipple graft. Definitely will be for a free flap, so you'll have more necrosis. So I want 6 weeks off. Yeah.
Any pros or cons for chest top surgeries to like exercising, not exercising for several months or before?
Before?
Yeah.
No, I think before you can do as much as you want and probably as much as possible. The more you're going to have a pec defined, the easier it's going to get to place the incision exactly along that pec border and give a very nice look. So, yeah. Yeah.
Had a patient just ask me about penile preserving vaginoplasty and if that's available in Canada.
Not to my knowledge. We're looking at these. So when I was talking about, the non-standard or now customized request, we have to start looking into that because we're going to see more and more. And we can't just discard that and say, well, it doesn't exist. So, but at this point, the short answer is no. I'm sure there will be. There will be pros and cons, of course, because what's the goal? Is it to preserve, erections, for example, but are you going to be able to keep that? Is it going to work perfectly? Are you going to be, what are you trying to achieve with that? Can we counsel you well? But we have to start looking at that for sure. Yeah.
Is there a higher incidence of phalloplasties now than 10 years ago?
Definitely. Not to the level of reaching the incidence of vaginoplasty, but we're seeing more phalloplasties, yes, and young individuals, yeah. They're ready to embark on the adventure. I tell them, it's going to be an adventure when we're both together in there, because we have to get to your goals, but there's going to be a few bumps along the way, right? I mean, it could be delays because of complications. Definitely there will be complications. Either it's stenosis, fistulas, or partial necrosis, wound healing delays and stuff like that.
What's the average length of time from beginning to
For 3 stages, it's at least probably a year to a year and a half is the very least you can expect, if everything goes well. Yep. For genital surgery, age of majority. Yeah, so I see them, I consider them, and I do operate. I've operated, the youngest kid I operated on was 14. Had a great parental support, had been, miserable, and again, not going to school and not feeling good. And top surgery actually gave him his life back, and he was able to reintegrate. And I think, if socially then he can gain that, why wouldn't I operate on him if he's 14? I mean, it's the right thing to do. Yep.
My question is, a lot of us are hormone therapy providers, so our patients are coming to us and asking us a lot of these questions. What do you expect from the primary care provider or the hormone therapy provider? How much information are you wanting, would be ideal for you?
In the referral letter, you mean?
Yeah, like even just like how much we're talking to our patients about risk versus benefits. I mean, I always say within my scope of practice, I think
Right.
this or that, but
Well, I think you just evaluate the overall plan, the expectations, knowing if it fits for you. Does it bring any, red flag that they might not be ready for surgery at this point because they're still, then they haven't reached really what you wanted to reach with the hormones. You have seen maybe some mental health issues that could be addressed, even if it's not your scope of practice necessarily, but you'll have a sense of, as a whole, of thinking, well, hold on a second in surgery, maybe this is not what you need right now. I think this is not, gatekeeping. It's just to make sure we're doing safe things, because we want to make sure that when we offer surgery, we're gonna reach, not perfection for phalloplasty, but at least, trying to reach for perfection and good outcomes. Yep.
Can I make a comment real fast? And, as the primary care provider, when we're doing those letters, if part of it too is we don't want our patients thinking, oh, I'm going to refer you to the surgeon, and they're going to see the surgeon. The surgeon's like, no way, because of these medical conditions or these issues, there's no way I can operate. So sometimes sort of helping patients kind of understand the surgeon's reservations, or if they have really out of control medical conditions, we need to get under control because I want to set you up to be the best you can. So when you see that surgeon, they're like, yeah, you're ready to go. So I think that can be really helpful as well, instead of just this templated letter that says, I've taken care of this person for a year and they understand the risks and benefits and go for it.
So I do apologize, because I could go on and on forever, but I have to go because, as you know, so we're hosting, we're organizing a little bit with WPATH, And but I'm going to leave a few cards here, so please reach out if you have questions. I'll take the time to answer. I'm sorry I have to leave a little bit early, but thanks for your attention.
Yes.
So I just wanted to correct one thing that I said. It's actually ftmsurgery.net or mtfsurgery.net.
I just want to make one announcement, and then I'm going to take more questions. For everyone, you're invited to the GEI reception tonight, and it's from 5 o'clock to 6:30, and it's in the creation room on the 6th floor. So if you're staying in the hotel, it's on the same area where the elevators are, where the lobby is, and you just kind of go around when you're coming towards away from the hotel, you can it's behind where the breakfast area is. So the room is called the Creation Room. So I hope that you will join us. Question.
It's not a question, it's just a plug, because I work in the surgical practice.
Oh, great.
The worst complications that I've seen in the short time I've been there are for folks who have uncontrolled diabetes.
Ah, okay.
So, I think if there's one thing that I would ask my primary care colleagues is get people's A1C down before surgery, because they're going to be in they're going to be at a massive advantage versus, even just that looking at the A1C of 6.7 or 6.9 or whatever, even at that level, it's really dicey.
Thank you. Thank you. Just to say another thing before we take more questions is that throughout the program, as you go through the conference, in Grand Salon A, that is where all of the SOC8 chapters are going to be going one after one after one after one, and some are going into the salon next to it. But if you stay in those those two salons, you'll see it on the left-hand side when you open up your program. That's where like the majority of the SOC8 chapter reviews will be. Any more questions? Yes. Mm-hmm.
I do have a question for the elite panel here, and it's going back to the previous one. Lots of talk about checking estradiol levels. I have heard some concerns about the reliability of the testing and the picogram level, and I just wonder if there's some clarification on when we ought to be focused on this and when we ought to not be, considering that, is 100 really different than 120 or 200 different than 300, etc.?
I think the biggest thing is not to overfocus. So, so the conversation this afternoon got a little bit into the nitty-gritty of peaks and troughs, and that's okay, except bottom line for people, if you're looking at numbers, is probably more likely to be total testosterone level because the estradiol is somewhat unreliable. And I think, and you heard, relatively, I guess we have to have simplistic thoughts, and I guess I would broadly say this. You heard numbers like target 100 to 200 and things like that, and okay, that's, it's a little bit like Alex said with guidelines for surgery. It's okay to just have a little something in your brain in terms of what's reasonable, but as a practical matter, if everything is working fine, I'm looking for the number to be bigger than 0 when somebody wants an estradiol. Undetectable makes me nervous, but 50 not so much. And I want the number not to be crazy. So 1,200, I really am worried, like Maddie said, that the person is just way overdosed for some reason. But 300, I don't know what that means actually versus 200.
Yes.
Can you speak a little more on the unreliability of the estradiol assays?
What more bad things? Okay. The only other thing I would say beyond that is there are we all have them. The occasional patient who has this sky high number and it doesn't even make any sense, and they're not even taking their estrogens, and so there's clearly some unreliability. The companies that I've talked to insist it's not true. That's the whole conversation at this point. They're like, "Oh no, doctor, you are mistaken. It's just you." Okay, so that's kind of the level. And I don't have anything more. I don't have any more wisdom.
Do you do the chemiluminescent assay or a tandem mass spec?
A mass spec. You're going to be more reliable, but even with the mass spec.
And if you see a level, like with any hormones, if you see something that just isn't making sense for the dose the patient is taking or how the patient is feeling or the changes they're seeing, just repeat it. Like if anything, sometimes I just tell patients, this is just for confirmation. I want to make sure you're not too high or too low for what we're aiming for. And a lot of times you are going to just see it sort of come out okay.
And yeah, oh sorry.
Yeah. Well, it's just patients do get really fixated on those levels, and exactly like I'm 142 and I need to be 180, and just to kind of tell people, I tell people I'm really concerned if you're really too high, because like I don't want to put you at risk of bad things that we know happen with really high levels, and so under that I don't care if you're happy, like, and I'm protecting your bones. Great, I'm super happy, and we can go from there. And so a lot of times, again, the hematocrits, just repeat them. If something doesn't look right for what you expect, just repeat it.
And I just want to point out one other thing, which is this is another example, I've said it a couple of times, where in the cis world it was considered done and settled legal matter or whatever, and it's just because they aren't looking. Because in the cis world you go by, if you have a uterus or menstruating, or you go by LH and FSH, and so we're identifying things that are probably true broadly in terms of assays and in terms of physiology, and we're going to have some things to share in the other direction too.
Yes, next question. Hi.
Is there any use at all of measuring free testosterone in test-nasty patients?
Conceptually, we would prefer to measure it if we could, but we just don't have the reliability of the assays. And I think that's really what it boils down to. And so we're ending up with mass spec total testosterone because that's reproducible. And then we know it's fraught because of the binding proteins. And we can even measure the major binding protein, SHBG. And then we can do some hand waving about, a little bit like albumin and calcium, except we don't have a good math formula.
Yeah.
Question about subcutaneous injection. Somebody mentioned in one of our other sessions about abdominal injection. Is that more common than thighs?
Michael?
So I generally, when the patients go for the subcutaneous, I generally start with the abdomen as a good site, just because most patients do have some fatty tissue there, even if they're quite thin, and patients tend to like it. And basically just tell them to kind of rotate and not to go in the same spot all the time. The abdomen is usually my starting point, but there are other sites that can be used as well. They definitely want to be able to see where they're going. I don't want a patient to do, like, for example, gluteal injections if they really can't see where they're putting the needle, so they really have to be able to visualize it well.
Anywhere you can pinch some fat is fine. I think and sub-Q for sure. I mean, there are definitely people who are like, I love this IM, and that's fine, that's okay. But I mean, I think sub-Q for estrogen injections and testosterone really is kind of the community standard of care now. And but the biggest complaint that people don't realize that you have to counsel people is there are people, because that oil is just going right under the skin, it can get itchy, it can get red. People all of a sudden are going to be like calling you on a Friday night, oh my God, I'm allergic to my testosterone and I can't take testosterone, and what am I going to do? And it's just an irritation reaction. It doesn't mean they can't do the testosterone. So there's all sorts of little hints they can do. They can take a Claritin, they can move around. Probably next week when they do the shot somewhere else, they're not going to have a reaction. You don't have to switch them necessarily to a Namphate right away, which can be very expensive and hard to find sometimes. And then now the pharmacy doesn't have it for a week, and now they're out of testosterone, and they go back to Cypionate, and oh my God, I'm just fine. So again, do some pre-counseling of expectations with the sub-Qs, because that's kind of the biggest thing that patients kind of freak out about.
And the sub-Q is just because it's less painful? Is
less painful, less invasive, easier. Patients don't get sort of that big needle phobia, like, and because also with intramuscular, over a long period of time, people get scarring, and then they're not good about doing their injections, and now they're having breakthrough bleeding, and they're super dysphoric and feeling horrible.
And my patients don't use the word just because when we're talking about less painful.
Yes.
Yeah, so how am I going to say this? We don't have any organized approach really, and I guess that's where it sits. And what's out there so far doesn't separate out the medical agents from stimulation. They're usually cocktails of a bunch of things. So it's some cool stuff. We even have a publication out of my institution with a trans woman who breastfed for a number of weeks actually, but with a lot of work that was more than just the galactagogue. So I just don't want to overstate it.
And there are some articles like Zill Goldstein's.
Well, that's the one.
Yeah, Zill,
Yeah,
and
yeah.
then there's another one I think from 2020. But they're out there. I've had some patients do it. They've been very happy, bonding. You know, it's been
Yeah, but the
really
point is that
special
not to
for it,
bank too much
but
on the galactagogue.
That's
Yeah.
fair.
Okay. Exactly, and but a lot of stimulation for the month or so before the kid was born. So there was much other. This patient was engaged from several different angles.
I've had patients, well, Dr. is like not available in the United States, but I've had patients with lactation goals around like their sexual like activity, like their life and their relationship to gender, who have wanted to use this long term and asked me to monitor things like prolactin and PKG for dontaridone, which can be teaching prolonging agent. I'm curious if anyone else has navigated this space and how you've done that.
Yeah, I guess I'm going into now I've got somebody experimenting on themselves a little bit. Concept that's making me nervous. That's kind of where I would be at that point.
Yeah, we've done it with one patient in California who's now been breastfeeding for a year, and we've done milk analyses as well, along with her cisgender woman wife, and they're nearly equivalent in terms of nutritional value.
Wow, that's interesting.
Yeah, have you published that?
Nope, no, that's on my docket to do.
Okay. Big deal.
So in that, that's a good place to end, I think. Yep. Okay.
So you, because I see a lot of patients that we start at 18 or the college age. So you do a bone density at 5 years on a trans male, and what if you see a decrease in density, what do you do?
So I can tell you that I'm most worried about changes in bone density if somebody's hypogonadal. And so that's where I really worry about bones, and I want to get a DEXA scan. So for example, if a trans woman had an orchiectomy and then was lost to follow-up for like 5 to 10 years for whatever reason, then I'd really want to get a DEXA. And in terms of how often to monitor and screen, again, it really is unknown, but as long as the patient either has gonads or they're getting exogenous hormones, then their bone density is usually going to be okay.
So I'd like to take this opportunity for thanking all of you for asking so many questions, and that's really what our goal is today, is to answer as many questions as we can. And we started out with like a bunch of questions at the beginning, and it just steamrolled. So I think that that's just wonderful. And to me, that's a sign of a successful course. So we will be sending you those slide decks. And I'd like to thank Erica. Like, she did the majority of the slide decks for the courses in foundations. No, like, that's not what I'm saying. Yeah.
That we noticed, so I'm going to ask that we correct those errors before we send them to you, because I just want them to be as accurate as possible. So I'll work on that tonight, and we'll get them out to you.
Yeah, and again, we want to ensure that there are no photographs on there, and when we were preparing the PDFs already, like we have different kind of PDFs, like with slides, without slides, so that without pictures, so you will not be getting anything with a picture, but if you do have some type of picture, it's going to be like a diagram. You will be getting your CME credits through the Whova app. They will be contacting you through there to complete that, and then they will send it via the app. And I encourage you to become more kind of conversant with the app, as that's how we're going to be accessing things throughout the conference. So I'd like to thank my faculty, and I'd like to again thank you, and please come to our reception. So thank you.